Good afternoon, everyone. Good afternoon, everyone. Thank you for being here on time. The guest of honor has already arrived, but he's in the VC signing the visitors book. So in a few minutes he's going to be here, and we apologize for being a little bit late, but in a few minutes he will be here. And I will request each and everyone when they enter to please stand up. Thank you very much. Thank you very much. Can we ask you for application? We would like now to welcome you officially, the guest of honor, the Permanent Secretary, Minister of Health, Karibu Shigalati. Thank you very much for keeping your hands together for you in this very important occasion. We would like now to welcome you officially, the guest of honor, the Permanent Secretary, Minister of Health, Dr. Shigalati. We can put our hands together for him. We have now Team Vice Chancellor, Professor Emmanuel Valantia, Minister of Research and Investigating Academics. You're right. We have Assistant Director of Oral Health, Ministry of Health, Dr. Baraka Soto. We have Coordinator of Research and Publication for your right. My name here. And we have the Director of Government Communication Innovation, Professor Naya. Welcome also to this occasion. Also to welcome all the representatives from different organizations, members of the government and private sectors. Like to welcome Dissemination reporter of occasion, time, distinguished researchers, faculty, students, partners, members of the media. Welcome to the 15th University Live Research Dissemination Symposium. Without wasting much time, let me welcome the Acting Vice Chancellor, Professor Emmanuel Valantia, who will give a proper welcoming remark. Karibu sana.
Deputy Chancellor, represented here by the guest of honor of research publication and secretary, Minister of Health, Sanagia, Honorable Saif Shitlagi, Deputy Vice Chancellor, Minister of Health, represented here by researchers, faculty, students, partners, Director of Research Publications, invited guests, ladies and Sanagia, representatives from Minister of Health, the guest of honor, distinguished researchers, faculty, students, partners, members of the media, invited guests, ladies and gentlemen. Allow me now salim for the guest of honor. It's a great pleasure for me to welcome you in this occasion. The 15th Municipal Festival Celebration Symposium. Allow me privilege and to convey our appreciation to you. I also extend for all agreeing to participate in the gracing this occasion, sparing your valuable time, alumni, to join us, and all those it is indeed a privilege and an honor to have you with us. Guests of honor, ladies and gentlemen, I also extend warm welcome to all the distinguished representatives from various institutions, researchers, partners, alumni, oral health, and all those who are joining us tonight. Guests of honor, ladies and gentlemen, we are truly honored to host this symposium with the theme Global Commitments into Lowering Advancing Oral Health in the theme Universal Health Coverage. And that is precisely this theme why is timely and reminds us that policies and strategies only become meaningful when they translate into real challenges in community. And that is precisely why we are here today to reflect, share evidence, and share practical ways to bring oral health into the higher education universal health coverage. Ladies and gentlemen, at once, this agenda is close to our mission, which is to provide transformative health training, conduct impact research, and deliver quality services by leveraging technology and innovation, transform our teaching and service. Ladies and gentlemen, I Our School of Dentistry has made remarkable strides over the years. Through strong collaboration with the government, development partners, and private sector, we have transformed our teaching and service environment. These advances will also expand the vision of the dental core integration tomography, or CBCT, and outreach, pronounced afterwards, OPG, explanations. We've also expanded clinical spaces and the integration of digital technology ensure that our graduates can respond to our strengths of training and service delivery countries in the region. Afterwards, we are also investing in the next generation of all health support and imaging by revising our curriculum to competent-based expertise. We ensure that our graduates can respond to the oral health needs of Tanzanians and the countries in the region with functional skills. MUAS has supported imaging dental schools by sharing curriculum, staff expertise, equipment, and training opportunities in the countries, contributing therefore to the nation but also regional workforce expansion. Of particular interest, based on our university was granted approval to establish the East African Regional Center of Excellence in all health sciences at the East African Community Council of Ministers areas this year. This Center of Excellence is planned to be constructed at the EU alongside Foreign Affairs, and the center will serve as a training, research, and service center for the region. And attract Tanzania further resources and request to address all health challenges. We thank the Ministry of Health alongside Ministry of Foreign Affairs and East African Cooperation, Ministry of Planning, Ministry of Finance. I want to say for their unwavering support throughout this journey, from contributing to the national, and we further request more support in realizing the objective of this center of excellence. More research that has generated evidence that shows policy, ladies and gentlemen, education and practice. Our research has been impactful achievements from contributing to the national oral health achievements, survey to exploring innovative digital solutions. More researchers are generating evidence that shows policy, education and practice. But none of these achievements are happening in isolation. All of these achievements are a result of strong support communities provided by the government through the Ministry of Education, Science and Technology, and therefore wish to convey our sincere gratitude to the government. They also reflect the strength of our partnership with other universities and institutions globally with communities and with many collaborators who are present here. I therefore wish to convey our sincere gratitude to the government and all collaborators. This symposium is more than an unwavering commitment in providing resources and support, a space that has ensured a seamless development, approval, and implementation of our nation's collective action. Ladies and gentlemen, this symposium is more than an academic event in the ministry. It is a platform for dialogue, a space to connect global strategies to local innovations, and a moment to inspire collective action. Thank you to our guest of honor. We deeply appreciate your outreach to you and the ministry. Thank our unwavering support towards our advancing oral health in Tanzania. Who have dedicated to our partners, faculty, students, and guests. Thank you for being part of this journey. I also wish to use this opportunity to thank our panelists, keynote speakers, and all participants who have dedicated their time for this important event. This is a symbol of your commitment and willingness to this cause, and I believe you will continue supporting the initiatives of our university for the government for the betterment of our society. Having said that, guest of honor, I now ladies and gentlemen, with those few remarks, I would like to once again take this opportunity to invite each one. I now wish, and as a single honor, to welcome you, guest of honor, to deliver your speech to the audience. Karibu sana.
Professor Emmanuel Kalanja, District Vice Chancellor, Professor Naya, Director of Research, Professor Emmanuel Balari, also appreciate your presence. Deputy Vice Chancellor, distinguished guests, Sanaya, Director of Research, Mwasalim kwa jina la Jamhuri ya Baraka Anikengia. I also appreciate your presence. I'd like to distinguished guests, thank the Almighty, ladies and gentlemen, for granting us this opportunity. Mwasalim kwa jina la Jamhuri ya Muungano wa Tanzania. Enjoy. First of all, I would like to thank the Almighty Allah for granting us. It's my greatest opportunity to be with you, whether we are invited here, seated, held guest of honor, enjoying to officiate important our life, research, dissemination, symposium. But secondly, it's my great honor to be with you, invited here this afternoon as a guest of honor to officiate this very important particular research dissemination for this significant contribution that Mo has on behalf doing into our country of the government of Tanzania through Ministry of Health. Let me take this opportunity. I bring warm greetings and express particular appreciation for this significant contribution that Mo has is doing Symposium into our country. Titled Global Community into Local. Let me take this opportunity as well in oral health to commend Mo Universal for selecting such a timely and a meaningful theme of this symposium, titled 1, Global Community into Local Actions into Advancing Oral Health within Universal Health Coverage in Tanzania Actions. There are two key words, but also advancing oral health within universal health coverage in Tanzania. Now, the country through Ministry of Health, in the next month, we are going to start implementing Bima ya Afya kwa Wote. That is an extension. That is an extension to make the local citizens enjoy the benefit of getting treated else wherever they are, regardless of their financial hardship. All that we are seated here, we know that once you are sick, you just have to have your card for NHIF, and then you will go to any of the hospital. You are not looking whether you have a single penny, how much do you have, but just your card. So you can imagine many Tanzanians were not able to have that opportunity, but rather when they are sick, they try to collect money from each of the relatives, and we have witnessed some of them here, they couldn't pay their bills. But we thank Her Excellency Dr. Samia Suluhu Hassan. She dared, and because she loved all the people in the country, she has instructed that universal health coverage be implemented as it starts from November. That's why even her commitment during this campaign, that was the first promise she made to all Tanzania. So that's why this theme, as it also touches universal health coverage, is very important. But not only that, it also mentioning global community into local actions. So I hope that local action that we are speaking, I hope during the research dissemination here, we'd like to see how we connect that local action. Ladies and gentlemen, oral health has often been overlooked, yet it is critical, important of overall health, quality of life, but human dignity. We do understand our health. There's a lot our teeth plays a huge role in how today we can stand here and speak. because the teeth has done its job by chewing the food, but also even swallowing. You can imagine if you don't have any teeth, how do you swallow? So sometimes we ignore oral health and think that it's only our legs, it's only our muscles that make us do what we do. But in fact, it is the oral health, the teeth, that if we chew the food, that gives us the energy, and then we can stand here and speak and we can talk. So this is very important. That's why you see most of the people, they overlook the oral health. But oral health is very important. You can imagine it in this country or in the world, if all people, they don't have teeth. I can imagine all the malnutrition that we are talking today. Kwamba watu hawali vizuri, hawapati zile nutrients, hawajui kupika chakula. Unaweza ukakila vizuri sana, lakini unaweza unafurahia chakula unapokila simply because we have a teeth. Unapokula nyama choma au whatever you eat. So again, I want to emphasize that often oral health has been overlooked, but yet it's very important in the component of overall health, quality, and human dignity. That's why, as a country, we are aligning with the WHO Global Oral Health Action Plan of 2023-2030, which provides a clear framework for a stronger and more coordinated action. So as a country, we are aligned to this, to the WHO Action Plan, which is for the period of 2023 to 2030, providing a framework for a stronger and more coordinated action. So following this, as a country, at the policy level, the ministry and the leadership for oral health has been strengthened through establishment of the Directorate of Oral Health Services at the Ministry of Health, of which Dr. Baraka is sitting there. So Dr. Baraka is a voice for the dentist, but also is an ambassador making sure the ministry, when we make the policies or any recommendations, oral health should be considered. So this is very important as a country, aligning to the WHO Action Plan. We have established this directorate. But also the regional TAMISEMI President Office, also we have a person who also is coordinating oral health. Ladies and gentlemen, integrating essential oral health services into primary health care is another important step. Our goal is very clear. Every Tanzanian should access quality oral health services without facing hardship. So the hardship here is explained in a meaning that the oral health services should go up to the level of the vituo vya afya, health centers. But also there should be wataalam, the doctors who will take care, whether it's at any level of the profession, whether it's a diploma holding, or it's a degree, or it's a master. But when you have the facilities and you have the professionals, but also, as I said earlier, people should have a Bima ya Afya of which they can access. That's why here, what I say, the goal is clear. Every Tanzanian should access quality oral health services without financial hardship. And this is essential, as I say, for achieving universal health coverage. You cannot achieve universal health coverage if there are other people who are left behind. So this is very important. Also, as a government, we recognize that a strong workforce is the backbone of any sustainable health system. A workforce is very important for the sustainable of health system. If you have enough human resource for health, you have sustainable healthcare system. Because there are people who will exit after they retire, and there are other people are taking over. But also the nature also take its own course. Some of us will die, some also will continue, and some also will now decide to go to other directions, so some other people will continue. So the ministry is working closely with the MOHAS and the other institutions to expand the training opportunities, revise curriculum, offer short courses, and share expertise across dental schools. These collaborations are essential for ensuring that Tanzania has a well-distributed component oral health workforce. We thank MOHAS because always from the Ministry of Health, if we think based on the need of the health system, but also from our community, there is a need to establish a certain cadre, human resource, to save our people. We've been in contact discussing, and MOHA always has been ready to establish and start another cause. So we thank you and we appreciate, and congratulations to MOHA. Ladies and gentlemen, MOHA has also achieved participation in the National Health Survey, and its leadership in digital health technologies are excellent examples how institutions can generate evidence to guide policy, practice, and innovations. So these are very important elements that MOHAS is doing. Innovations, research, so the data generated will inform the policy, what we should do. So this is very important, and we rely on those findings from the research that you guys are doing. But of particular note, I wish to commend MOHAS for being granted approval by the East African Community Council of Ministers to establish the East African Regional Center of Excellence in Oral Health Sciences, of which the Deputy Vice Chancellor Academic just talked about it. This is a milestone achievement that positions MOHAS in Tanzania as a regional leader in oral health training, research, and specialized services. The Ministry of Health will remain fully committed to supporting MOHAS in this endeavor. But if that is not enough, in general, as a government is also committed to working hand in hand with the academia, development partners, civil society, and the private sector to advance. The aim is to achieving the national target. And in order to achieve the national target, it is very important that we all have a shared responsibility and commitment. In order to achieve that target, we must have a shared responsibility and committed through innovations, training, research, and funding. All these elements I've just mentioned, if we have a shared common understanding, community, and shared responsibility in these areas, then we are going to achieve our goal. So the Symposium offers a powerful platform to share evidence that inform policy and practice. I encourage all of us to think boldly and act collaboratively. The future of oral health in Tanzania depends on us, and it also depends how well we bridge global commitment and our own commitment into local realities, You know, sometimes you may hear people coming presenting from other countries abroad. They are going to prescribe some of the things that they are doing in their country, which they are not. It's not easy to practice them in our context. That's why here I call upon that whatever we are doing, the global community should be localized, should be customized into our environments that we are able to do. For example, you may go in Europe or wherever, you find some of the people, they brush their teeth using electric, brush. So that is theirs. But if you go in our home villages, kule kwa baby zetu, they can't use that. Nahitaji kwanza kucharge, you have to buy batteries, whatever. But then you need to ask yourself, that electrical and the other one, they can do just the same thing. Only what you need is to teach people how they can brush their teeth properly. So it's very important, that we should not take on board any prescription that people they bring to us. We should see, can it work in our environment? That is very important. Ladies and gentlemen, before I conclude, I just want also to remind you, I know I want to be with you here to follow all the dissemination of the research that you have done. I wish I could do so, but I have other commitment. And I love research. Some of you guys here, they know my background as a researcher. I really love research, but I really love the data, because it's only the research and the data that we generate, they can help us to change many things. But I want to advise you that whatever the dissemination will be here, and the good thing Baraka is here, let's see whatever the research we do. The research we are doing, do they answer the oral health problem that we are having in the country? If they do answer, Baraka is here and they can hear. Let's see the problem we were having last year in terms of the oral health problems. Researches that we are doing, how much have they reduced these problems that we are having? So I was thinking to hear at the end, maybe as you conclude this symposium, to see, we planned to do this, the intervention research to address the problem of oral hygiene or the problem whatever. After doing this in the intervention, now we have been able to reduce from here to this level. But at the end we know now what will be the new research questions that we are going to embark from the next year. Then when we meet here, we know it is always important to the research to address the problems that are having and see that there is a progress, positive progress. It means reducing the problem that is there. So I want to be here, but I have the book I'm going to read, but I just want to advise you that whatever you discuss this, think about this. Sometimes I challenge my colleague, are we doing research to address our local problems, or are we doing research because a funder, a development partner, will bring money to you and you tell, let's do this research, which is not necessarily answering your problem. If you don't have a funding for that, what you need to do, you do both. Do his or her job, but also use the same funding kwenda kufanya kazi ambazo zinajibu majibu ya kwetu. That is very important. But also pakifika mahali, you guys, you want to do something to address the problem that we are having, and you don't have any funding, andika proposal, bring to us. See, then come on, you need billions of money, or you need millions of money, And you know, maybe it's just a survey to school children or whatever. That's not a lot of money. We can always look for that funding, especially you can attach that ikawa ni one of the research for a student of the undergraduate ambaye anafanya masters yake. And I'm more than happy to work with you to see that we look for that funding and making sure that we address our problems. Ladies and gentlemen, I would like to once again commend MUHAS for its leadership, vision, and continued partnership with the Ministry of Health. Together, let's keep this pushing forward to ensure oral health for all is part of a strong, equitable, and resilient health system. Ladies and gentlemen, once again, I thank you for inviting me to be guest of honor in this short period of time. I appreciate that, and please take my word. Whatever you are going to discuss here, I'll be leaving out, but just remember that I am with you always, because you are discussing something that is also addressing the problem in the ministry that I am. With these remarks, it is my honor to officially declare that the 5th MUHAS University-wide Research Dissemination Symposium is officially open. Asanteni sana.
We can put our hands together once again for the for officiating our symposium. Thank you very much. We can take our seats. Now, in this symposium, MUHAS has prepared a token of appreciation to our guest of honor. Can we bring it here, please? We want to give you something that you can remember us by it. It's a token of appreciation, and it's talking about its recognition your outstanding leadership and commitment to advancing oral health and universal health coverage in Tanzania. It has been given in this 15th World Research Symposium. Thank you very much. This is a way of appreciating you taking your time come here and what you have done so far with regarding to oral health and universal health coverage. Thank you very much. You can take a seat now. Thank you very much. We have some few pictures that we'll take here, and then the guest of honor, together with High Table, will go out. They will have a brief with the media, and then as he has spoken, he will be leaving. He would have loved to stay, but he has other commitments. But during when they went outside, we will continue with here. Can you just come here and stay behind the High Table? That's the first picture. Deans, directors, head of units who are here, who will be represented as the principal. Deans, director, heads of units. You can stand behind and have a good picture with the High Table. It's going to be the analyst, chairperson, and key speakers. This is going to be the second picture. Analyst, chairperson, and keynote speaker. There's some coming. mention other hospitals around here. This is going to be the third picture.
Government institutions and private institutions invited, who are here representative from different clinics that have been invited, dental clinic, I know, a government institution, some people from ministry, different ministry who are here. Last but not least, as for the students who are around here, undergraduates and postgraduates, all the students who are around here. I would have loved to ask the School of Dentistry, but I don't know how big it is here. So I'm just wondering if that is wise. But I will call you anyway and we'll see how you can fit yourself in. The last one is going to be the School of Dentistry. The staff, and if we ask, the students are already here. Ya upendeleo sasa, School of Dentistry tafadhali. Thank you. Thank you so much. Thank you so much. Asante sana. Now I would like to, in honor of our guest of honor, all of us will stay aside. They will have a minute with the media. And I ask the rest of us to remain here so that we can continue with our program. We will have some bites that will be passed through as we continue.
Thank you very much. Since our time is gone, I think we can continue. And as they go outside, we'll have some bites that will pass by, and then we'll continue eating while we continue. And now I would like to welcome the chairperson of this session to continue as the first keynote presenter is preparing. The chairperson of this session. Yes, please. Professor Irene Kida, you can come and continue with the session. Yes, as they continue with presentation, we will having some bites, so we'll continue eating, and the people will bring here.
Thank you very much, MC. Okay, so dear members, let's start our session on keynote address, and I would like to call upon the first speaker. Maybe before I call upon her, I can just say a little bit about her. Yes, Dr. Alfonsina Masaku Manai is a public health professional with over 2 decades of experience in prevention and control of communicable and non-communicable diseases. Her bio is in the compendium, and so with no further ado, I would like to call upon Dr. Alfonsina to talk about the first session, the first keynote, which is titled World Health Organization Global Strategy and Action Plan on Oral Health 2023-2030, What is Happening in Tanzania? Welcome, Dr. Alfonsina. Let's give a round of applause.
I'm happy to be here. As we are waiting for the slides, I wish to introduce myself again. My name is Dr. Alfonsina Manai. I'm happy to be in Muhimbili again. I graduated with my colleagues there 28 years ago. Obviously, 28 years ago. It's the age of something. We also have elders with us. I only have 10 minutes, so I'll try to be brief because I know that I've seen the program. Those in the panel will be able to speak more and elaborate more. We'll only present areas that are relevant for the 10 minutes. tutaje nisaidie na slideshow.
Hapa, hivi hapo ndani.
Mtaweza lazima tukapata. Lazima ende katikati pale.
Kwa ajili
si anaongea. Kwa lazima ataenda pale.
mtu anaongea. Mtu anaongelea hapa hapa. Anaongelea hapo kwenye podium. Anaongelea hapo kwenye podium.
Asante. Oral health lies under non-communicable diseases, and it was until 2011 when the world realized that there was a problem with non-communicable diseases, when everybody started having serious problems, and probably even in developing countries. So that is when we had the first political declaration by heads of state. And in this declaration, oral health became one of prioritized areas. And after political declaration that was in New York, that time, we then went to regional declaration, which was called Brazzaville Declaration. This was in Africa. And the African region prioritized again oral health in the list of other conditions like sickle cell, like diabetes, hypertension, and many others. Oral health also became one of those. Despite these advancements, there have still been disparities in how we have been dealing with oral health, among others, because we had a group of major conditions and other NCD conditions. So the major conditions became cardiovascular conditions, respiratory conditions, cancers. These were taken as major ones, leaving aside oral and sickle cell and other conditions. So there has been efforts by WHO in collaboration with member states to improve an area of oral health. And as we can see, we had the first strategy for oral health developed, and then an action plan together with that strategy, and then a regional strategy aligned to the global strategy. And as we are moving, we are also going to the national level. So my presentation will mention a few things. One is on the global health, the Global Oral Health Action Plan and its regional framework, and the global strategy inclusive. It will also share some cost-effective oral health intervention packages that WHO proposes, a model list of essential medicines, and a snapshot of what is happening in Tanzania. And this is mainly WHO support. As I start, I wish to commend progress made by the government of Tanzania, because so far, Tanzania is among countries leading or taking a good step in oral health generally, if you compare to many other countries. When we did our first assessment some years ago, the country was back. Maybe to mention on my own work, I've been in WHO for 15 years, and in the 15 years, I've worked with NCDs and these areas for like 13 years so far. So I will be sharing what we did that time in 2012, when oral health, even in Tanzania, was quite low. We were counting chairs, dental chairs, we were counting facilities, where are they? But as we go now, there has been good progress in this area. So I wish to commend that, and as we discuss, we will be sharing what Tanzania has so far reached. Generally, oral diseases are the most common diseases globally, and around 42% of the population in the African region is estimated to be suffering from major oral diseases in 2021. These were estimates in 2021. And the same African region experienced highest increase in the number of oral health diseases cases in 30 years. Coming into what we do as WHO, we have 6 major functions. And in our functions, one is leadership in health, creating evidence, tracking what is being done, supporting capacity, resources, and others. So in our tracks on the evidence on the different conditions, we take data from countries and we analyze them at global, regional, and sometimes national level. So if you look at what is happening at the global level, oral health scored the first. So you will see here, whether this can, you'll see here, this is number 1, which are oral diseases. And then the score goes to, that is global level. The score goes to neurological disorders as the second. And I think we know what neurological orders are, like epilepsy, dementia, Alzheimer, and those other conditions. And then digestive diseases take number 3 globally. And then we have respiratory infections and TB taking number 4, skin diseases 5, sense organ diseases 6, which are ENT, eyes, and others. And then musculoskeletal disorders 7, which is also increasing. We have NTDs and malaria taking number 8, HIV, TB, and AIDS, HIV, AIDS, and TB taking number, and STIs taking number 9, and nutritional deficiencies taking number 10. But if you look at the second lines, they show how those rate by World Bank, low, middle income, or upper, or the other. So you can see number 2 that is in most of these World Bank low, middle income, upper somehow, and high income, number 2 is digestive and neurological disorders. While to us, number 2 goes to communicable conditions like NTDs and malaria. And if you look at the other low income, we have neurological disorders going low, but our conditions are a little bit not as high as others, especially when you come to communicable diseases. But you see that among all the changes that we see, the different colors, light blue and yellow, are dispersed around, but it's only oral health that sticks to number 1 across all countries, or middle income or high income countries. As we said, there has been underinvestment in oral health. Half of the countries do not have oral health policies. More than 70, this is in the African region, more than 70 of the countries spent less than $1 per person per year on treatment costs for oral health care in 2019 versus the global average, which was $50 per person per year. Only a limited number of trained oral health professionals are available in the African region. Example, dentists for 100,000 people was around 1/10 of the global ratio. So there has been this situation. Tanzania is changing, but there has been this situation across the African region. So we do have strategies that began to improve this situation. You can see we began with a resolution on oral health in 2021, which resolved to change the situation in oral health and improve it. And then following that resolution, the strategy was developed, because after resolution, you go to develop what the resolution guides. And this strategy was developed in 2022. And in line with that one, we had an action plan developed 2023, covering a period 2023 to 2030. At the same time, when the strategy was developed, an action plan was also being developed, but it started on 2023 to 2030, so it's still in action. And then after that, the regional strategy took over, which was in 2026, trying to accommodate itself in line with what the global strategy is. So if you look at the global health strategy, it has Let me go to the next slide. So when we look at the global strategy and action plan on oral health 2023 to 2030, we have 6 main objectives. And these one is on oral health governance, oral health promotion and disease prevention. We have health workforce, oral health care, oral health information systems, oral health research agenda. If you look at them, they're mainly aligned to the 6 WHO building blocks, almost. So in there, we have different actions that have been proposed. We have 100 proposed actions for member states in this strategy. We have actions proposed for WHO. We have actions proposed for international partners, actions proposed for community organizations, and actions proposed for private sector. And in these actions, if you look at the total proposed actions, we have 22 talking about governance only. We have 22 actions for the promotion and prevention, 16 for health workforce, 18 for care, and information systems 10, and 12 for research agenda. Since there are many, I've not showed all of them how they are, but I will read generally what they talk about. These actions in the different areas, we have action that deal about policies, and I will be aligning it with what WHO does and the government does. We work hand in hand with the Ministry of Health and other ministries at national level. So when we talk of policies, we are talking about policies that should be globally available or guidance globally. And that guidance will be taken by the region, and the region will be guiding the countries what to do. So these are the areas where the policies is talking about. But it's also talking on the policies that deal with, like, do this or don't do this. Or it's guiding what should be done in what aspects, because we have many challenges related to promoting, the promotion everywhere, regulations and all that need policies. So when you come to another area, it's about action, implementation itself. And implementation, we look at all levels. We look at the central level, how do they implement? Hospitals, how do they implement? Communities, how do they implement? Private sector, how do they implement, and what should they implement? So when you talk of actions, all those actions are there. I might go to each one. And mentioning quickly, we have areas of capacity building, we have areas of implementation, as I said, we have areas of risk reduction in the different areas. I think we all understand the risks that are under oral health. We have areas of integration. We had the Permanent Secretary mentioning what should be integrated and at what level, at the primary health care level, but also integrating it at the different levels, different sectors, different private sector, what should they do? It has taken areas, it has also mentioned about engaging people living with oral health conditions. And engaging people living with oral health condition is a prerequisite for all people living with NCDs. It's how we have been engaging people living with HIV. Also people living with NCD is part of that. And we also already have a meaningful engagement document for people living with NCD, which was published by WHO in 2022. And it guides how we should engage these people. So that is also included. It also talks about marketing, and especially for the private sector, about how the private sector should abide to national oral goals and global goals. It talks about occupation, emergencies, all other causes that can lead to global health problems. For instance, now we have a lot of accidents and we have many people having facial injuries. What do we do, and how should the strategy align to that, and what should it do? So it's also mentioned there. It's also talking about private-public partnership guidance, how to use data, monitoring, and research. These are among few areas that are in 100 actions that we've mentioned, and we're not going to mention all of them, but we will share this strategy for those who don't have. So after that, the 6 strategic objectives that we mentioned about governance, about promotion, what we do is we track implementation in those areas. And you can see those, the track that we do is by country. And in this case, the ministry will clarify should there be any problem, but we have some data that shows where are we with Tanzania and how far are we moving. So we have an overarching goal which takes the whole global strategy itself. And there, I will read there. One is universal health coverage for oral health, and the intention is to have by 2030, 80% of the global population is entitled to essential oral health care services. 80% of the population. If you look at globally, our baseline was still at 23, almost like a few countries with that one. And looking into the region, our baseline was at 17, almost like 1 or 2 countries with that close to achieving that. But that's the target that we said we are going to take ourselves. And this because they are global and regional targets for Tanzania, that's not applicable. But in that overarching goal, we have one that aligns to the country, which is reduce oral health disease burden by 2030. The combined global prevalence of the main oral disease and conditions over the life course show a relative reduction of 10%. So this one we do have a target there for Tanzania, baseline for Tanzania, which was 41.7%. So we didn't start that bad. Actually, we are close to the global standards. And then the first one now in the objectives is oral health governance. So what we are tracking along the course is national leadership for oral health. And in that one, we say by 2030, 80% of countries have an operational national oral health policy, strategy or action plan, and dedicated staff for oral health at the ministry or other national governmental health agency. So this one is, we look at what is happening in a country, and we do follow this through surveys that we do, like a country capacity assessment for NCDs. And when we do these country capacity assessments, they're presented in the high-level meeting, which was in September this year, to show the progress we are making in NCDs, including oral health. So for Tanzania, you can see there, this has been fully achieved, and we commend the government for that. And I think the Permanent Secretary has mentioned it very well, that we now have a team at the Ministry of Health, but also in PURAJ. And we are, that one, so the activities and most of the things that oral health is moving is because we do have these people at this level. And then the other thing is environmentally sound oral health care. And that says by 2030, 90% of countries have implemented measures to place, I don't see measures to phase down use of dental amalgam as stipulated in Minamata Convention on Mercury, or have phased it out. This one, you can see for Tanzania, it's fully achieved. And maybe we would wish to compare with what the other documents are saying. You can see the global and region, they're still low. But for us, we have already achieved. So we are among those countries that have made progress. As we say, Tanzania is making progress. However, I wish to mention a point there on the use of mercury. I will mention again, we have another initiatives together with other sectors. And you can see we are downscaling mercury in oral health, but mercury is still being used. Where is it used? In mining, yeah. So we are trying something, but something is still happening. And I even approached one of the focal points for mining, and I asked them, don't you know about this Minata declaration, Minamata? And what do you say? And that person, it was an informal discussion, but from the other sector.
They say, but what do we do? It means we have to have an alternative before we tell them to stop. So you can see these are the challenges we are having as health. We know what we want, but how to make them actively implemented. So the other is on oral health promotion and oral disease prevention. Here, we monitor policies, presence of policies to reduce intake of free sugars. By 2030, 50% of countries implement policy measures aiming to reduce intake of free sugars. Here it's partially achieved for Tanzania because we have some things happening, but I think the panel will mention more about this area. But there are countries that have already addressed it in full, like in South Africa, they had a policy and something that was passed about the sugars. For here, I will mention what we have done as WHO in the next slides. And the other one is optimal fluoride delivery for population oral health. By 2030, 50% of countries have national guidance on optimal fluoride delivery for oral health of the population. This one for Tanzania, we are yet to, and I believe our doctor will say something here. The thing is, what we are supposed to do is to see how we make this available in a better way, not relying entirely on the knowledge of the user, but rather availability that the user can reach it early or appropriately. So I think in our discussion we will see how to improve this, and there will be some parts of the discussion. In the health workforce, we have one thing that we're monitoring, innovative workforce model for oral health. 50% of countries have an operational national health workforce policy, plan or strategy that includes a workforce trained to respond to population oral health needs. I understand we once did an analysis of oral health of NCD workforce nationally, but we need to, the information has not gone up to the regional level, but Tanzania did that analysis to see how much do we need, what do we need for NCD. And I believe oral health was one of them. We will look at that because we need to see when we're saying our gap is this one, then if it's NCD, then it has to include the oral health details. But still, in the efforts that are ongoing, we have had that ministry is already working, MOHAS is already teaching. So I think there is a document that guides increase of these people. The other one is integration of oral health into primary health care. We can see that I'm not going to read this, it's fully achieved. And then the other one is availability of essential dental medicines. 50% of countries include dental preparation listed in the WHO model list of essential medicines in their national essential medicines list. What I've followed here is our essential medicines list that we had didn't have a detail of oral health, apart from the needs that we use in maybe our own work. But like toothpaste that is required, the efforts are required. Some countries have chosen even to buy through MSD, like a supplier, so that when people get it, they get the right levels of milligrams, I think you call them something, the levels of fluoride in the toothpaste. So that one has gone to that level. So in our case, what do we do? We have private companies here. Some of the toothpaste don't show how much of the fluoride is there. So if they don't show, we buy them, we use them. I've bought, I've used. Before, never did I know that they were enough or not. So what do we do to improve that? All of us, and agree that we improve this availability of better items. As I said, some countries chose even to import or buy and then supply. The other one was monitoring implementation, and this one is 80% of countries are monitoring framework for the National Oral Health Policy Strategy or Action Plan. We would say this one has not been achieved because we are in the process. And I believe as we speak later, we will see that there are efforts already ongoing. Under oral health research agenda, 50% of countries have a national oral health research agenda focused on public health and population-based intervention. This is yes. And as we, Permanent Secretary put it very well today, that MOHAS has been at the forefront, plus other partners. So these are major indicators that we monitor and follow at national level by the region. And they help to show where are we, in addition to other interventions that will appear in the strategic plan. Okay, here we can see here this very important point that it shows most of the countries haven't achieved this. It's not Tanzania alone. And it's an area that we need to strategize, and I believe the panelists will discuss it very well. So we do have a book called Aware Antibiotic Book, and then we have another document here. It's written the Selection and Use of Essential Medicines 2023, where the WHO Essential Medicines list has already included what should be part of the mental health products that needs to be available and included in the essential medicines list. So long as this list is being revised now, and it has started at the field level, once it reaches our areas, then we will be able to have this included. Once included, then it will help to show what can be done. So I'll go with the first one. It's on fluoride, and it says the type of gel, what should it contain. I won't read the details, but it also shows about what should be in mouth rinse, toothpaste, cream or gel, and in varnish. These are items you know better that are used for oral health. And if we have this is the amount of fluoride that needs to be in those items. And what we need to do is to ensure if anything is sold, then it has that. So this is what the national level can do, having those available and agreeing to pass them through Tanzania TMDA. And this one are the ones that can be imported in the country or even made locally, but of that level of fluoride. The other thing that we need to do is glass ioma cement. I think this one, I'm not a dentist, but I think this one is the one that replaces mercury, is it? Eh? No, oh, yes. Yes. No, this is something different.
The ones which is...
Okay, so in the panel we will explain better. So this one is single-use capsules, you can see, and multi-use bottle. So it shows what should be there and how much should be there, and per mil, per liquid, or something. So when we say we are including it in our essential medicines list, which is under review, it means this has to be part of it. The other one is resin-based composite, low viscosity, single-use applicator or multi-use bottle of any type. So this is what we should do. I would explain a little bit better. But here we also have integration of WHO listed dental preparation as part of National Essential Medicines list. It's also one of a need. The other one is to conduct steps with oral health module. And I think this one, the PS has mentioned it, PS has mentioned it already, that we did it this time in 2023. So we achieved that one. Health workforce integration. This normal we don't have in Tanzania, do we? Or some areas we don't have. And then the other one is oral health policy with dedicated budget and staff. And I will explain this in the next. So to finish, these are areas that we had a meeting. WHO, how we work is we work with Ministry of Health, but we go together and we discuss on what can be done in the countries. And the ministry is there. So Mr. Baraka was in this meeting, I believe. You were not, but somebody represented. And there were topics on oral health. and there were decisions that were made on oral health. So after we do those decisions, we work by tracking what is being done from the other side. So we help put them in place and track them as well. So here, these are the things that were passed in August 2025 in Lusaka. And Tanzania was able to present very nice things that I've asked Baraka to share about this. But we also had an oral health meeting in Bangkok ahead of this one, which was a global meeting and then a regional meeting, where we have our decisions and they are used to track where we are. So here, maybe let me not read them all, I might read them in the next slide. These are things that we agreed, and in our discussion we might see if these are the things that were agreed, can we do them in our panel, what can we do? So here we have policy options that are easy to implement and cost effective. Like one, implementing a population-wide mass media campaign on use of toothpaste with fluoride of that concentration, as we said, silver diamond fluoride for arresting dental caries, glass ionomer cement as a filling material for cavities, and I think, as you say, some of these are done. Some of these we will hear how much of the progress has it been made. But you also had early detection of oral cancer and taxation of sugar-sweetened foods. These are among the quickest. So if you look, we had a survey that was done last 2 weeks, and this survey was doing a comprehensive cancer assessment nationally to see where are we, the skills, the efforts, infrastructure, and all these big things that you can hear about cancer. So when we did that, we also did assessment on prevention. And you can see that the prevention that we had, and so this was WHO, IAEA, and International Cancer Research. We had some recommendations there on prevention, and you can see here, there are recommendations on tobacco and alcohol, healthy diet, physical activity, but underneath we have consider increased taxation for high sugar containing food items. We had others for other NCD conditions, but we had surveillance and monitoring, partnerships, and community engagement. You can see that all that has been proposed here, it's something that cuts across NCDs, but also beyond non-communicable diseases. So in this area, we were thinking, I hope in the panel, we will see how we can integrate, enhance, and integrate prevention strategies together. Because some of them are common and can be dealt together, and some are single. Like in oral health, we have all those that we mentioned about use of fluoride, use of, well, those are specific. But even if it's specific, can't each be integrated when you talk of something else in another innovation or intervention? So I'm not going to go much into this, but we can see that there is some relation. So just to finish up, what is happening in Tanzania, some of them I've mentioned. One, currently we are working with the Ministry of Health to develop a new oral health strategy, which is in good shape, but still work in progress. And I believe what is being recommended globally and regionally will be included in the new areas that the region has just decided. But this is work in progress. The other one is what we did, is the steps which the PS has mentioned, and the results are now available, and they can be accessed through WHO website. We will share this link with you on what we did and found on oral health, and it truly showed still there's need for services on that area. The other one is we are collaborating with the Ministry of Health, even the local government and Prime Minister Office and other sectors to develop a framework to monitor social determinants of health, the EPT, aimed at enhancing joint decision-making and tracking progress. We started this activity 8 years ago, and it's not final yet. What we have done, we started with 12 ministries, where we started telling them what do they need to do under health. And at that time, it was when we had in MV Ukara, Ilivyorondoka. So we had that meeting with the PS and the Secretary of PS who opened the meeting, Prime Minister's office. He said, the NV Ukara one was a disaster. It could be either diplomatic, economic, or personal, whatever, because it was good that the health department was well organized and more than 200 bodies were buried with respect. But we asked a question, that is not what we want by health. Health, we want to avoid those deaths, especially people should die reasonably, not, I don't know how, and so we mean people should die when at least there's no option. But if there is an option of saving lives, then we should save lives. So we told them, but what about having life jackets in these boats? Couldn't we save many people? And this is the eye that we need to see, the eye that we need to be addressing. So we shared with the other sectors on this, on WASH, and many other, like cholera. We should see cholera. There are many factors: water sanitation, water safety, availability. You can see the major area could be availability. So it means it's not again health, it's another one. So we did a framework on this one, and this framework, later all ministries were supposed to join, and this framework is still work in progress, and it will deal with these other areas as we speak, including looking for maybe out of pocket and many other things. And we have a monitoring tool that was launched 2023 by WHO, where indicators to monitor social determinants have been included in the policies will be monitored as well. So once this is passed, it will help address many of these aspects. The other thing that we have done is essential health service package has been updated by the ministry recently, last year to this year, and this essential package was reviewed. The last one was 2013, I think, the last package. So this one was a new one. And every program was engaged. I believe the oral health was also engaged as part of NCD to see what is there. And this one is the one that was used to guide the benefit package. And the benefit package is the one that now comes into universal health insurance, of which the PS was mentioning. So this one has just been made last year with the support of WHO, and we might have to check it again on the indicators for oral health to see if they are all included, if not forgotten. And the other is revision, okay? The other one is a recap project. We did a recap project with the ministry. This is under health prevention for NCD, which was looking at the free sugars as well as physical activity. And in that project, why did we have the recap project? We came to realize food is sweet. I'm trying to go fast, I'm just at the end. Food is sweet. So once food is sweet, you won't say don't use it, because people like it. So the decision was to go to legal reforms that can help producers and industries reduce sugar, rather than telling somebody stop sugar, because they wouldn't stop it, because they like it. So this is where we were, and we did an assessment with legal advisors, and this project is still ongoing, and we will see. And it wants to guide producers and private sector and industries to label amount of sugar, label what they have, but also educate people. I'm about to finish this one. The other one is, I think the cancer I've already mentioned. The last one is a collaborating center that government wants to do on NCD. We believe it can work with MUHAS as well. It will be in Nimri. And the last one is on, which is important, is on detection, early detection. In early detection, when we did cancer, we mentioned about early detection, but we are used to the major NCD. Have blood pressure in your facility, have weight and scale, and we are forgetting early detection for other areas like oral, eye, and one. So it means when we are making a package for early detection at primary healthcare level, then we need to include all these and say how this can be done. Given that now we have health insurance, it's easy to advocate for early detection. Thank you very much, and sorry for listening.
Thank you very much, Dr. Christina, for a very insightful presentation.
So thank you so much for sharing with us. Sharing us and describing strategies that led to the organization global strategy for oral health, and the strong recommendation on risk-first approach and early detection for disease. So I would like now to invite the second keynote address speaker, and this is Matilda Mtaya-Mlangwa. Dr. Matilda Mtaya-Mlangwa is a senior lecturer in the Department of Orthodontics, Pedodontics, and Community Dentistry in Memphis, and she's currently serving as a coordinator of the East African Center of Excellence in Oral Health. She's going to give a presentation on the excellence in Tanzania, the role of MUHAS School of Dentistry in advancing WHO Global Oral Health Strategies for 2023-2030. Welcome, Dr. Matilda Mtaya. Let's give a round of applause. Thank you, Madam Chairperson. Representatives from the government ministries, Ministry of Health, and Dr. Barak also, and very much get difficult pronouncing this, Pure Ranch. Dr. Kingia, deans and directors, development partners, and private sector, distinguished researchers, faculty, students, partners, members from the media, invited guests, ladies and gentlemen. Nawasalimu kwa jina la Jamhuri ya Muungano wa Tanzania. My name is Matilda Mtaya-Mlangwa. I'm a senior lecturer in the Department of Orthodontics, Pedodontics, and Community Dentistry, former Dean School of Dentistry, currently project coordinator, East Africa Center of Excellence, Oral Health Sciences. I am very honored to stand in front of you and present on towards pursuing oral health excellence in Tanzania, focusing on the role of MUHAS, School of Dentistry. Okay, do you all hear me? Even at the back? Thank you. So the role of MUHAS, School of Dentistry, in advancing WHO Global Oral Health Strategy 2023-2030. Now this is from global, we've just heard from the previous presenter, to local. Focus now is on the school, what is happening at the School of Dentistry. So this is the very content of the presentation. Quickly, I'll take you through the historical background. The school started way back in 1979 as a division. Then in 1991, it became a faculty. And then in 2002, when all the schools at Much by then became schools, the School of Dentistry was one of them, to 2007, with the MUHAS becoming fully fledged university to now. To date,
The School of Dentistry remains as the pioneer of training doctor of dental surgery in Tanzania. You know that it is responsible for over 90% of dental surgeons and dental specialists in the country. But we are commending government efforts because currently new faculty of dentistry have been established. SUZA, the State University of Zanzibar, and University of Dar es Salaam, Mbeya campus. The School of Dentistry continue to receive students from within Tanzania and beyond. We receive students from Tanzania and East African countries, Southern African countries, even Europe, and even some Asian countries we receive students. That's our vision and our mission. Our role at the School of Dentistry is in line with MOHA's function, that is teaching, consultancy, clinical services, and research. We have a number of undergraduates, postgraduate programs, and undergraduate program. Soon we will start a diploma program, diploma in dental laboratory technology. And this year we are going to start a new bachelor program, that is Bachelor of Science in Dental Laboratory Technology. But in future, we are going to have a number of demand-driven programs. We're going to have super specialty programs in endodontics because we don't want teeth to be extracted. We want to conserve as many teeth as possible. And Master of Dentistry in prosthodontics because we don't want those who have lost teeth to stay without teeth. And Master of Dentistry in Periodontology and Master of Dentistry in Anesthesia. So in order for us to train efficiently, we need training facilities. We have the school, and we have other training facilities like ranging from classrooms, well-equipped dental laboratory, well-equipped x-ray rooms, phantom rooms or skills laboratory, and dental units and specialized clinics, as well as standby generator, because we don't want to be, our activities, our functions to be interrupted by power cuts. So on the WHO Global Strategy and Action Plan on Oral Health 2023-2030 that we've just heard, our objectives of the school, objectives of MOHAS align very well with these functions. I don't need to repeat, we've been taken through them very elaborately. Specifically, in terms of the role of innovation and technology, we utilize digital dentistry at the School of Dentistry. That includes the use of digital radiography, CAD/CAM, 3D printing for improved diagnosis. This is very important for improved diagnosis and treatment. As regards to oral health information system, we make use of reliable data. You know that reliable data is key for planning and improving services. So we use existing data to improve services at the school. On expanding access to affordable care, this is really important. At the School of Dentistry, the MOHAS dental clinics are pretty much affordable. But they're affordable, but we offer high quality care. And the services are accessible to low income and vulnerable groups. But also, where we do have subsidized treatment options. And we train students. And on training students, we train them while serving community. We see patients. And then overall, we contribute to universal health coverage by reducing financial barriers as much as possible. We have a number of outreach programs. We reach out to the underserved and vulnerable groups. We do have primary school activities. Primary schools in rural areas are not left out. Children with special healthcare needs, we follow institutionalized children, we give them relevant care. Oral health education, screening and preventive services, we do them very much in our community dentistry rotations. And in the process, we bridge gaps in access of care and beyond. We are in the forefront supporting other dental schools. We have already told you that the government is working hard to start new dental schools. So we are in the forefront in supporting them. So MUHAS is a hub of support to emerging dental schools. For example, for the State University of Zanzibar University Dental School, we help them in curriculum development. We support them in training students and mentoring and training their faculty. We've even went further donating 10 dental chairs because we know that proper training needs proper equipment. And then for the Mbeya Dental School, we support them in teaching. Our staff travel to Mbeya and assist in teaching and clinical training. But we also donated 30 dental chairs to them so that they can have necessary equipment for the training. For other dental schools, we continue to help them in curriculum development. Broad aim of doing this is that we want to build a stronger national oral health workforce. As you know that the government is working very hard to equip dental clinics all over Tanzania. They are really well equipped. We are commending really the government. So we need now oral health workforce to be all over. For oral health promotion and partnership, MUHAS connects communities, industries, and policymakers to ensure oral health interventions are impactful and sustainable. For example, we know that we have collaboration with Colgate and Whitedent. These are toothpaste companies to improve access to affordable fluoride, the one that the WHO representatives have just talked about. So we make sure that when we do outreach programs, children do get these toothpastes. And we bridge the ministries, Ministry of Health and Ministry of Education, and dental professionals in the country through the school-based oral health promotion, oral health programs. MUHAS as a driver of universal health coverage in oral health, we build workforce, we train students. We build workforce capacity through training and mentorship, continuous education program for dentists and allied health workers. We provide evidence for policy through research. We do various research which are impactful. For example, those related to assessing oral health related quality of life among Tanzanians. And then we extend services to underserved communities via outreach, school programs, and community dentistry in the community dentistry activities. We mobilize partnership with NGOs, industries, and international institutions and government to strengthen service delivery. For instance, through our collaboration with international institutions, we managed to give further training to our faculty. Recently, we managed to send 4 faculty in Europe so that they can have upgrade their skills for proper service delivery and teaching. So this pyramid shows that at the bottom of the pyramid, we do our teaching research. In the next level, we do our service and consultants, but at the top, we want to achieve national oral health excellence. Through our practice throughout, we find out that the demand for programs, demand for care is increasing. We get a number of applicants who want to pursue undergraduate and postgraduate training. So as I said, the school was built in 1978 and the program started in 1979. So at that time, that building on the left, it will be on your right maybe, that is where we are, and that building was just 2-story. And we saw that the demand is increasing. More students want to study, and many patients want care. So we expanded it from 2-story to 3-story. But now we reached a point we cannot expand it anymore. So it called for a bigger building. You see that building on the other side. So that is where we are going. Now, at this point, I'm going to take you to the East Africa Center of Excellence in Oral Health Sciences at MUHAS. This is a step towards pursuing oral health excellence in Tanzania and beyond. So this is also to properly execute WHO Global Strategy and Action Plan on Oral Health aligned with MOHA's functions. We need facility capacity expansion. We need capacity building of staff in the school, in teaching, research, and services for appropriate sustainability. Say origin. So I'm taking you shortly to the origin of the East Africa Center of Excellence idea. This idea came in 2022. It is a practice of East African community. After every 3 years, they inspect dental and medical schools. So in 2022, when we were inspected, the East African community was very impressed. And the School of Dentistry emerged as the top of the East Africa dental schools. So they threw this idea to us. Why don't you become a center of excellence? And we immediately grabbed that idea and ran with it. So on top of that, establishment of the East Africa Center of Excellence Oral Health Science is in line with East Africa Heads of State's health sector investment priorities of 2018, emphasizing on establishment of super specialty initiatives for the region. We should note that in East Africa, in East Africa community, they are encouraging having more centers of excellences. And the more center of excellences you have, the more you become on top. So at this point, our president, during the meetings of all heads of states of East Africa, when she presents 3-4 centers of excellence, she becomes really powerful. So we know that we already have these centers of excellence in other countries, as you see there, as they are listed. But Tanzania now, we have 3 centers of excellence. We have the one in cardiovascular diseases, and when we were approved with the Center of Excellence Oral Health Sciences, we had another one being approved, that is Center of Excellence in Transplant and Hematological Diseases, hosted by Benjamin Mkapa Hospital in Dodoma, and this one for oral health. So apart from that, this establishment of East Africa Center of Excellence is in line with SDGs, Universal Health Coverage, and WHO Global Oral Health Strategy. So establishment lies in the fact that oral diseases are highly prevalent but kind of neglected NCDs. This highlighted the need for a dedicated regional center of excellence. So to address, in order to address the needs in treatment, prevention, rehabilitation, and workforce training across the region. So this slide shows the milestones oral health sciences. As I said, it started the idea came up in 2022, and in 2023, the concept and initial consultations began with the support from the EAC Secretariat, East Africa Community Secretariat, and the ministry, all the relevant ministry. We were highly supported, and we appreciate that, by all the 5 relevant ministries. And in 2022, we were supposed to do stakeholders engagement to have that buy-in within the nation. And we did that. And then in 2024, we had to do regional presentations, and we presented the concept at the Regional Steering Committee of Centers of Excellences of East Africa, and then we presented the concept to the Sectoral Councils of Ministers of Health of East Africa in March 2024. In the process, we were supported by all the countries of East Africa. You know now there are 7 East African countries, so all 7, we were supported by all but one country. One country was shaky in supporting us, but we learned that they had an agenda. They were impressed by the idea, and they were thinking of, if it is possible to grab the idea. But we were told at the meeting that we should do country consultation That is, we were supposed to move from country to country, each and every East African country. So as to get the buy-in of those countries, we had to generate input and put those input into the concept so as to enrich the concept. And we did that. We did country consultation. We went through all East African countries and present our concept. And we were really, really supported everywhere we went, apart from that country. But slow, at the moment, we've already done pre-feasibility study, and full feasibility study is underway. So throughout the process, we really appreciate government support. The government consistently showed commitment towards establishment of the center. First, by confirming that. Second, providing its approval and expressed its full support. And lastly, endorsed. This concept was endorsed by all 5 relevant ministries, namely Minister of Education, Minister of Health, Minister of Finance, Minister of Planning, and Minister of Foreign Affairs and East African Cooperation. So those ministries assured their commitment towards supporting and financing the proposed center. So this photo was taken during the approval of the East Africa Center of Excellence on the 9th of May 2025. We really appreciate support rendered by the government and also MOHAS management. So the aim of this center is to contribute to development of appropriate and highly skilled workforce in oral health sciences to meet the immediate labor market needs and support to implementation of the East Africa Free Labor Market Protocol. Before we go further with this, we had to know about the burden of oral diseases. So literature tells us that in the world, 3.5 billion are affected, with a high prevalence along the East African countries. And it is well understood that oral diseases and conditions are caused by lifestyle mostly. These are behaviors, for example, random snacking, sugary snacks and drinks, alcohol drinking, smoking. These are really not friendly with oral health. And we cannot overlook the role of genetics and also other environmental factors, for example, presence of systemic diseases. In Tanzania, human resource shortages is evident. We have dentist population ratio estimated at 1 to 125,000 against the WHO recommended 1 to 10,000. So we are a little bit behind. Overall, the distribution of oral diseases shows inequality in access to oral health services. So specifically, if we look into one condition, one disease by another, dental caries, we have dental caries, which is very common. So this one shows the caries teeth. It's a common oral condition with estimated prevalence of 33.1%, meaning that in every other third child, there is a dental caries there. And of these, 91% of them are having untreated form of the condition. So considering the adults, 76% of all adults have dental caries, with almost half of them having missing teeth, having half of those who have the condition, and 45 having decayed. 45% of those with caries are moving around with untreated dental caries, and 1% of those are the ones who have filled teeth. So at this point, I'd like to come to call for all of you and the rest, and to emphasize that dawa ya jino sio kumoa, jino linatibika. So dawa ya jino ni kulitibu. Another condition, periodontal diseases. So these are diseases of teeth supporting structures, such as gums. And in Tanzania, 62.8% of adults have gingivitis, and 10% almost have severe form of periodontal breakdown. So this condition is associated mainly with just poor oral hygiene. If you brush, you're going to be very fine. And some of them are associated with NCDs, for example, diabetes mellitus. And some of the severe forms of this condition have been associated with low birth weight, women giving birth to low birth weight in infants. And partly, this is a sequela of chronic systemic inflammation. And this condition is the one that is responsible for a bad smell in the mouth, which is a common problem to some people. Oral cancer is another problem. In low middle income countries, the oral cancer prevalence and incidence is from 0.12 to 4.1 per thousand, and amounts to 1.2 of all cancers in Tanzania. And also in Tanzania maxillofacial daily practices, it shows that there are about 120 cases seen per year of oral cancer. And in these photos, you see these oral maxillofacial tumors. The sizes are because of advanced stages of the condition and the impact of late reporting due to inability to timely accessing care, which is a common problem in African countries. You find that in other European countries, they have oral cancers, but then some of them come with a very small sized lesions. Oral trauma is another problem. The prevalence of up to 9% has been reported, largely due to motor traffic accidents, and more so due to accidents by bodabodas. Malocclusion is another problem. This is a condition of badly arranged teeth and jaws, affecting 61% of Tanzanian children, with around 10% greatly requiring urgent intervention in form of orthodontic treatment. So people come or walk around with such teeth. The problem with this, such children are really impacted. Their quality of life is really impacted in terms of they cannot openly speak or answer questions in classes. So some of it might be reflect in performance of a child in class, because they feel shy to talk in front of people with such badly arranged teeth. So this condition is very much treatable. You see the cases on one side before treatment, came to our clinic and got treatment on the other side. So it is possible to. Another problem is dental fluorosis. The condition is associated with having motor teeth, affecting 31% of the Tanzanians, particularly those residing in northern part of the country. This is mostly associated with having, in the areas, fluoride content, much fluoride content in drinking water. Rationale for Oral Health Center of Excellence is we want to achieve affordability and cost-effective treatment. We want to do collaborative partnership, tailored education for the local context, diversity in cultural change, opportunities for research and innovation, reach sustainable development goals, alignment, addressing dentist to patient ratio disparity in Africa, and ample clinical practice opportunities. Specifically, Tanzania, as well as other East African countries, faces workforce shortages, severe shortages in some areas in the field of oral health, with a limited number of dental professionals to meet the population needs. But dentistry is a field of growing technology. There is rapid technology growth. So we want to grow with the rapid technology and advancements in dentistry. So we will employ the use of AI diagnostics, digital tools, and if you look at it, these are not fully integrated yet in training and practice. So we want to achieve that. The School of Dentistry recognizes the urgent need to strengthen capacity, expand specialist training, and integrate innovation in oral health care. And also, oral diseases, including dental caries, periodontal disease, and oral cancers, remaining highly prevalent, requiring advanced diagnostic and treatment capacity. So what will the center do? First, training. We will train undergraduates, postgraduates, specialists, super specialists, and regional workforce development. We will include also leadership and management in oral health services training. In addition, it will greatly address the issue of enrollment capacity which we are currently facing. We are really facing enrollment capacity issues. So we will address by having this center for local and foreign students. Research and innovation, we are going to generate evidence, develop local solution, and we are going to attract grants. For service delivery, we are going really to perform state-of-art oral health. We are going to have a state-of-art oral health hospital, advanced in diagnostic services, integration of digital dentistry and innovation, cautious sedation units, outreach programs, local and regional referrals are going to be employed. And in that act, we are going to do medical tourism. The outreach program, this issue came up really well, loudly, when we were doing country consultation, when we are moving from one country to another. All of them requested us to have this outreach program. For example, in Burundi, they specifically said, if you can, they said, do you know that you have generated already data in your country? So we wish you to help us to have, because they say that they don't have data on oral health diseases and condition distribution in their country. So it came out very loudly. And for regional integration, we are going to have staff-student exchanges, partnership with other regional centers of excellences, and cross-border care. For example, currently, after having heard that we have been granted, we have been approved as a center of excellence, already we are getting requests from other countries in terms of other countries wanting to do internship or to bring their students in Tanzania. So it's a big thing for the country at the moment. Specifically in innovation and technology, indeed we are going to do digital dentistry, expanding the use of digital radiography and 3D printing issues in diagnostics and treatment improvement. Oral cancer detection, this is very important. You've seen how huge and how fatal this can be. So advanced early diagnostic technologies to reduce late stage detection is very important. And we're going to do teledentistry. This will bridge urban-rural gaps by enabling consultations and follow-ups remotely. This is very important. Technology in training, we are going to have simulation lab, e-learning platform, enhancing student competencies. And the impact for all this is that we're going to improve accuracy, reduce costs, expand access, and ensure equitable service delivery. This is just a picture showing those digital radiography and advancement treatment options. You know, now we do maxillectomy, mandibulectomy, but sometimes if you just leave them after mandibulectomy, remove of the mandible, remove of the maxilla, we really impair quality of life of the patient. But we have advanced treatment option to improve patients' quality of life. This is the intraoral scanning. All these equipment are going to be there at the Regional Center of Excellence. Intraoral scanning, with this one we can reach many. We can help many, even in referral, to have this proper diagnostic aids. Painless dentistry. Dentistry is being scared for it causing pain. Everybody's scared of the pain of the needles or drills. So we are going to have painless dentistry. So I think this one will be friendly even for children. They'll enjoy the care because you come to the clinic, you'll be injected with no pain. This is advanced diagnostics for early cancer detection. So benefits of this to Tanzania, it will host the first regional center of excellence, positioning it as a regional hub for oral health sciences. Health benefits, it will reduce the need for referral. This is very important. It will reduce the need for referral abroad. In the process, we are going to save foreign currency for the country. Economic benefits, we are going to do medical tourism. We are going to attract grants and local employment is going to be possible. Policy benefits, strengthening NCD's control and universal health coverage efforts. To MOHAS and higher education, It will strengthen MUHA's academic reputation as a top university in sub-Saharan Africa. And also to increase opportunity for internationalization and in the process of partnership, staff-student exchange issues. And also it will enhance capacity in specialized and super specialized training in various areas of dentistry. And also it will create a sustainable platform for research funding and publication. To the EAC and internationalization, this will promote regional cooperation on NCD and oral health. And also it will build a critical mass of oral health sciences for the whole region. It will enhance EAC competitiveness in higher education and health sciences. At the moment, if you come to the list of top universities, you can just scroll them from Northern African countries or South Africa in particular. But with having such centers, we will be able, as an East Africa region, to compete with those Northern African or Southern African universities. And this will align with SDGs in areas of health, education, partnership, inequality reduction. And also it will be in line with EAC Heads of State Health Sector Investment Priorities of 2018. So how the center will strengthen oral health through increased training capacity, research and quality of dental education will result into stronger and more skilled oral health workforce, which will enhance service delivery and access to advanced oral health care. In the long run, it will improve oral health outcomes for Tanzanian population. Financial sustainability of the center. Borrowing from the experience of running the School of Dentistry MUHAS, we are going to develop a sound financial business plan, local patients fee, we are going to utilize medical tourism, student fees, research grants, and establishing collaboration with health insurance agencies and other institutions. Being the center of excellence, for sure, is going to attract more donor funds. And this is the site for construction of the Center of Excellence along the Mloganzira area. And way forward and recommendations. We are calling for the government and partners to strengthen the Center of Excellence for Training, Research and Innovation, expand digital technology for diagnosis, services, delivery and data collection, build a national oral health information system to guide policy and resource allocation, increase outreach and community services for vulnerable population, foster partnership with government, private sector, and ready to lead Tanzania towards oral health excellence, where we are going to train, do research, do consultancy service in that dream building you see over there. These are my references. Ladies and gentlemen, thank you for your attention.
Very much, Dr. Mutaya Mlangwa, for the insightful keynote address. And thank you very much for sharing us on the role of MUHAS and School of Dentistry in advancing World Health Organization global oral health strategies. You also shared the historical background of the School of Dentistry and the role of School of Dentistry according to the core functions, that is training, research, and patient care. You also showed that the school is well aligned with the World Health Organization Strategy and Action Plan and its vision to drive universal health coverage for oral health. You then shared the East African Center of Excellence for Oral Health Sciences, its development, its current status, and you also shared the burden of disease, which showed how necessary the center will be and how helpful it's going to be for the Tanzanian patient, Tanzanian community, and the region of Africa. So you also say what it will do and its benefits, and share the recommendations and the way forward. So let's give a clap to Dr. Mutaya for the presentation. So thank you very much for your patience. Now I would like to us to start for the next session on the panel discussion. So we will have a discussion that aligns with the World Health Organization Global Strategy and Action Plan on Oral Health, with its vision to achieve universal coverage of essential oral health care by 2030. Now, without further ado, I will start calling our panelists, and let me start by calling in Dr. James Kegia to come and join me here. Yeah, so Dr. Kengia is trained as a dentist and is a public health specialist, currently serving as coordinator for the research, publication, and oral health at the President's Office, Regional Administration and Local Government in Tanzania. Our second speaker will be Dr. Joyce Masalu. Dr. Masalu, join us, please. Dr. Masalu is also trained as a dentist and a public health, and she's currently a senior lecturer in pedodontic and community dentistry at the School of Dentistry in Aarhus. Karibu, Dr. Joyce. Our third speaker is Dr. Baraka Nzobo. Dr. Baraka Nzobo is trained as a dentist as well, and he's a public health specialist, currently serving as an assistant director, oral health services at the Ministry of Health. Our fourth speaker is Dr. Kazi Mashoto. He's coming out. Dr. Mashoto is trained as a dentist as well, and is an epidemiologist and public health expert, currently serving as Principal Research Officer at the National Institute of Medical Research, NIMRI. And our other speaker is Dr. Everest Wilson William Halia, Dr. Everest Dentistry, and coordinator of the Directorate of Postgraduate Studies. I'm Irene Kida Minja, an associate professor in the Department of Restorative Dentistry, and will be chairing this session. So thank you everyone for being here today. Thank you very much for being here today. So I will start by asking you questions. And you are welcome to this must align with broader health policies, which is must align with broader health policies and universal health coverage frameworks. So the question is, given the current governance structures and the Ministry of Health strategy, what concrete steps can be taken to integrate oral health indicators into national health planning and universal health coverage, ensuring accountability at both national and regional levels? Welcome to respond, Dr.
Thank you very much. As the Ministry of Health, sectoral ministry, we have already achieved, first of all, making sure that the all healthcare facilities providing oral health service has well equipped with the state-of-art dental chairs. We have digital periapical dental X-ray. We don't have to use analog periapical X-ray. The oral health facility now uses digital periapical dental X-ray. But we know that in universal health coverage, we need specialized dental service. And the specialized dental service cannot be provided without a well state-of-art diagnostic tools. So we have managed to have 3D cone beam computed tomography. Up to now, we have already supplied 18 CBCT to the regional referral hospitals, to zonal hospital, and this are being supplied to the regional referral hospital. So we need someone from Sumbawanga, from Kigoma, from Twara, from Ruvuma, to have access of this state-of-art diagnostic machine. But we went further. Up to the district hospital, they are now installing the OPG. At the Ministry of Health, when we speak about the orthopantomograph machine, this is for the primary healthcare service. My friend will talk about it. But it is all 184 district hospital has to have the OPG. That is the vision of the Ministry of Health. So by doing that, we are sure that implementation of UHC, every Tanzanian will have access to this state-of-art diagnostic machine. But also in the preventive part, we know that we are not focusing only on the treatment, but we need to prevent the oral health disease in Tanzania. As Dr. Nanai, during her presentation, talking about the fluoridated toothpaste. We know that we have a lot of fluoridated toothpaste in the country, but the Ministry of Health has already adhered to the WHO Global Oral Health Strategy on abiding to the recommended fluoridated toothpaste. And as the ministry, as the sectoral ministry, we have already write and send the instruction letter to the Tanzania Bureau of Standards, who is currently managing or supervising this fluoridated toothpaste in the country, that whenever you are giving the certificate for the toothpaste dealers, these are the standards which the Ministry of Health and the WHO recommend to be supplied in the country. For the children, we need a fluoridated toothpaste with 1,000 parts per million of fluoride. And for the adults, we need the fluoridated toothpaste which have 1,450 parts per million of fluoride to be supplied in the country. And I'm aware that the TBS has called upon other East African countries, their regulatory agents, to discuss on how they are going to abide with the movement of Tanzania. So we prevent the Tanzanian that. So I urge you, all of you, I don't know, I know some of us in this room, they are not the dentists, but whenever you are going to the supermarket, to the farmers, when you buy the fluoridated toothpaste, my friend, you have to look to the fluoride contents in the tube. That is it having 1,450 parts per million of fluoride. If it don't have that contents, please don't buy that fluoridated toothpaste. Look for the fluoridated toothpaste which have that kind of the standard. Also, in terms of human resource for oral health workers, at the ministry, we have already set the guideline that for the regional referral hospital, we need a minimum of at least 4 dental specialists: the maxillofacial surgeon, restorative dentist, orthodontist, pedodontist. Again, at the regional referral hospital, we need at least 4 DDS. When we went to the zonal referral hospital, we need a maxillofacial surgeon, we need the orthodontist, we need the pedodontist, we need the restorative dentist, and we need the prosthodontist. To the national hospital, many of them. But this is the challenge to the Muhimbili University now. You are the old university, and you are the mother university in dental issues in Tanzania. So, what we urge at the Ministry of Health for the MOHAS is to expand the enrollment of dental specialists. We need at once a total of 282 dental specialists in the country at public health facilities, not private. But when you count the number of dental specialists in the public health facility, leaving behind the MNH at the regional level, not more than 5. So we need that. We have a huge scarcity of dental specialists in the country. So the Dean, you are here, my friend Dr. Machibia, this is the opportunity for the MOHAS to expand the number of dental specialists. And the Ministry of Health is ready to provide sponsorship to any enrolled DDS for postgraduate start working at the public health facility. So I call upon all DDS who are here. If you want to become a dental specialist, please come to my public health facility from the national, zonal, regional, up to the district hospital. Whenever you get an employment there, secure an admission letter for postgraduate start, apply for the Ministry of Health sponsorship. The government is ready to sponsor you for your postgraduate study. Thank you.
Thank you very much, Dr. Nzobo, for sharing what you have accomplished so far and also challenged us on increasing enrollment for postgraduate students. Okay, so the second presenter will be Dr. James Kingia. Dr. James, even though primary health care is the backbone of universal health coverage, yet I think we've heard from even previous speakers, oral health is often underrepresented. So how can health services be effectively embedded in primary health care, particularly in rural and underserved regions, while making sure that sustainability, workforce capacity, and quality of care are maintained? Please welcome Dr. James.
Thank you very much. From the previous speakers, but also as we are discussing UHC globally, primary care remains the vehicle towards achieving the UHC. You can really not run away from the primary care. And here I'm talking about the very comprehensive picture in terms of all aspects of care, from promotive, preventive, curative, and rehabilitative services. But with the experience in Tanzania, what we are seeing with the current investment, the first initial step towards advocacy, we need data. Data has been key in terms of understanding the gaps. So it's only if you have the data in the situations, prevailing situations, then you can advocate to the decision makers. We've done this previously to different platforms, and we've seen that it's really helping. That we are seeing now oral health being in the bigger picture of the government. And the other thing is we really don't need to move alone as a separate entity as oral health, but rather to have it as one of the movement within the bigger movement of investment within the primary care. And of course, in Tanzania, we've done that, and it's very clearly in some of the documents. If you go and read the Health Sector Strategic Plan 5, that of course translates the health policy in Tanzania, we see oral health clearly stipulated at page 38 as a government, one of the important movements in terms of investment. And all aspects of oral health are pointed out there, from the preventions, even the issue of basic services to be offered in Tanzania. But of course, having it in the Health Sector Strategic Plan 5, that's one thing, but another very important milestone that we've made is to make sure that also oral health is within the instrumental tools that are available within the PHC for planning. And if you go and read the comprehensive cancer health plans, the CCHPs, and also the facility plans, because since 2017 in Tanzania, we have the concept of direct facility financing. All the resources are being transferred directly to the facilities. And then there you can see very clearly among the 13 priority areas, with the priority areas number 4 for non-communicable diseases, we see also OROS as being part and parcels there. And because of that one, the investment that we are seeing now for primary cares, we really utilize these kind of opportunities. And if you have already managed to put them in the document, then that becomes sustainable. You have them in the document, and then people are budgeting it through the same modalities. Of course, as pointed also out from different presentations, everything is possible only if you have the human resource. And we've seen different efforts from the government in terms of now. Initially, we did have some of the facilities, even at the level of the councils, they are missing the opportunity to offer oral services. But now, all councils in Tanzania, 184, we have OROS being delivered. The struggle is now to capture all the health centers. But strategically, through strategic investment, we've done almost now more than 50% offering oral health services, and we are choosing them strategically in those areas with high needs. But our wish is to have all those facilities also offering oral services. And of course, we'll go there and expand as much as possible to other areas. And the other thing that I've been asked is the issue of quality. The quality is also important. Of course, we are doing all those investments, but we need also to think about quality. And here, all of us are actors for the quality of care. Talking about all the technical competences, the role of the university becomes key now, developing people who really can deliver the oral health in terms of qualities. And one thing that we are forgetting, apart from the technical, we need also to orient ourselves and our students toward the health system responsive domains. You know, we can technically treat our client very well, but what about all other non-health needs? Talking about proper communication, attention to our clients, confidentialities, and all those other aspects that are relevant to comprehensive treat our clients. Having said that, maybe I stop here and wait for the others.
Thank you very much, and we really appreciate you sharing the importance of embedding oral health in primary care and how important it is to have data in order to convince decision makers, and also to embed into the existing efforts of NCDs. But also you emphasize on the need for human resource for health and also the quality, not only in clinical care, but also in other aspects of patient care. So thank you very much, Dr. Kingia. Our next speaker will be Joyce Vasalo. Yeah, Dr. Vasalo. So prevention is key to reducing oral health burden and costs within the universal health coverage. So the question is, what evidence-based strategies for oral health promotion and disease prevention should we prioritize nationally, and how can communities, schools, and health facilities be mobilized to implement them effectively? Welcome, Dr. Joyce.
Thank you, Madam Chair, and Professor Irene Kida. Jamhuri ya Muungano wa Tanzania. So I'm very happy today that Jamhuri iko hapa. Kwa hiyo, if we have a word, we just pass it to the Jamhuri. My task is to talk about health promotion and disease prevention. Maybe it's just ceremonial because those are the subjects that I teach. Much has already been said, starting from our WHO person. She talked about sugar to be reduced, and the mechanism that is being proposed is to increase taxation on food items which have a lot of sugar. But she also mentioned about use of fluorides. That the the majority of Tanzanians should be covered by fluorides. So I will stick on those two areas, but I will go back to basics first. In health promotion, we have 5 action areas. We have building healthy public policies, and here we are not only referring to the health policy, we are referring to all ministerial sector policies that they should contribute to enabling people to have control and improve their health. I can see from WHO to the ministry, all the policies actually are towards enabling people to have control and improve their health. So there are 5 action areas, policies. I have already said we have them nicely written. But the second level is to have supportive environments. When we are saying sugar should be reduced, one mechanism is to increase taxation, which I totally agree. And that will also be in line with a common risk factor approach to prevention. If you deal with sugar, you are doing a good thing to teeth, but at the same time, to other non-communicable diseases. So for me, I totally second that one. Foods which are rich in sugar should be liable to heavy taxation so that people will be not forced but helped to choose wisely. They can eat alternative snacks and foods instead of sugar. Now the issue of fluoridated toothpaste. The issue of fluoridated toothpaste is very important. We have sufficient evidence that topical fluorides have actually done wonders in preventing dental caries. And at some circles they say dentists are very clever because they managed to put themselves out of work by preventing dental caries using fluorides. But in this part of the country, maybe we have not come close to that. We are not going to put ourselves out of work. So for me, and now that the Jamhuri is here, I am recommending that we revoke taxation for toothpaste and toothbrushes, just as it was done for sanitary pads. Sanitary pads were very expensive because of taxation. But for us, toothpaste, this one is a therapeutic agent, but yet it is being categorized as a cosmetic product. Even toothbrushes, these ones are required for blood control, but also for supplying toothpaste. I mean, applying toothpaste in the mouth. So if we can do ourselves a big favor and stand as advocates for the voiceless. When I say voiceless, I mean people who don't know dentistry. We are the ones who are trained and we know that fluorides are therapeutic agents. So if we remain silent, we don't tell policymakers and others who are involved. So we should stand as advocates to speak for the people we save. That if it was possible to remove taxation on sanitary pads, which is a very good thing, I strongly recommend that toothpaste and toothbrushes should be tax-free, or if it's not possible to have them completely exempted from taxation, it is to reduce the tax so that a tube of toothpaste may be bought at a quarter price. In that regard, we will achieve the universal health coverage by sending preventive actions far and away from towns, even in rural areas. They will afford. But another thing that Jamhuri iko hapa leo, let us remember that the fluoridated toothpaste that we have, from previous studies actually, it was indicated that most of them have the required parts per million as indicated on the label. But if you go to the lab and do detailed analysis, you will find that the bioactive fluoride that is available for karyostatic effect in the enamel, you find that the levels are much, much lower. So I'm requesting and I'm strongly recommending that, apart from just saying that fluoride should be incorporated in our toothpaste, but also TBS and whoever is enforcing or checking if standards are being met should also satisfy themselves that the fluoride ions are available, or in other words, they are bioactive for caries prevention. So that is in response to what our WHO person has said, but also what the director, in the past we used to call the director for oral health services chief dental surgeon. So if I say chief dental surgeon, it's because I'm being traditional. I'm not disrespecting you, but chief dental surgeon for the ministry, because we look into that. We have also talked about the quality of life and things like that, people walking with untreated disease. We have now researchers who can assist the Minister of Health to test interventions. They can test interventions by using rigorous methods and see, are we going in the right direction? Have we given the right dose? Have we used right methods? So again, I'm inviting the Jamhuri to use its researchers. Some of them are here at this university, even in Nimri. People have tested very rigorous community trials, and we can continue to do that to see if what we are trying to intervene, actually we are succeeding, and we can come up with a model that can be adopted for the whole country. Maybe this should be enough for now. I have tried to make it short. Maybe I didn't say much on the prevention, but prevention, actually we are dealing with risks, and on the other side we are dealing with the host factors. So for the fluorides, we are actually making the enamel more resistant to acid attack. But for sugar, it is a risk. It's the one that will produce acids to destroy our teeth. So in prevention, actually, it is embedded in that. So don't say I haven't said much on that. And integration now of services, especially in prevention. We are doing a lot of work in primary schools, through school health programs, as our people from Jamhuri have said, we train our DDS students, and you're my witnesses. You can testify that we usually go to Morogoro, teach you how to deal with the primary school kids in their schools, but we also give our dental students an opportunity to interact with mothers in RCH clinics and give them health education, try to demonstrate how to brush, talk about winning foods, the importance of vaccination for febrile illnesses in children in the way it is related to oral health. All those are being covered in their practical training during their Morogoro rotation. Thank you, Madam Chair. Maybe I should end up there. By the way, I'm too talkative.
Thank you very much for emphasizing on what has been discussed before, and also on the importance of controlling sugar and the use of topical fluoride, and also to utilize the available researchers here to test the interventions. Thank you so much, Dr. Joyce. So the next question is to Dr. Everest Wilson. So as we know, digital dental technologies can improve access, and digital dental technologies play in strengthening service delivery and data collection in Tanzania. And also, how can their adoption be scaled across both urban and rural settings? Welcome, Dr. Everest.
Thank you so much, Madam Chair. The question was too long. It's a joke. So it's about digital technology. Talking about oral health, we have the application of digital technology is vast, but the question was specifically for data management, so we can make decisions and improve health of our people. So we know that data managements are not, there are those that are specific to oral health that we use in our clinics, but also at the level of the ministry and other stakeholders and people who are doing field work for oral health. Those are targeted at collecting patient data for, then they'll be used to analyze and make some decisions. So data is key for daily business operations, decision making, planning and management, but also eventually it will help also, it will provide evidence for policy making. But also it's important for communication and data sharing. But now data, the main challenge with the data in our setting, it's most of the time is fragmented. Everyone has his or her own system, and it does not take data from another system. So a pooled decision making is difficult. So we need some sort of integration of the systems that we use, so we can help decision making at different levels of governance and management. But also, so fragmented but also isolated. Again, another thing is, even with the systems that are available, most of the time the data is missing some details. So you find you want to make a decision, but when you analyze the data, it's not complete. So maybe we need to put some controls in the systems that we use, so that you are not able to log out into your management system without completing all the required data. So to make the data available and to seal the gap of missing data. So, but also normally the system that different facilities use, again, so we need also to integrate our data management systems into other non-communicable, into other relevant health conditions like the NCDs. So when you have a doctor doing, feeding the patient's information, they can also pick some basic oral or dental data for your consumption, because at some point these people are seen by other health practitioners than they are seen by the oral health practitioner. So we need to establish an essential package of data that we can also get from other stakeholders in the field. Not only the medical practitioner, but it can go beyond that. Even we have seen in primary health care, they also use community health workers. And we are not sure whether they have any oral related training, because these are important people to help us to correct basic information. And so they need to have a basic package that we make so they can help us retrieve or extract the data from the population. Yeah. So that can also help us scale the patient data extraction to the community rather than to just the clinics, where we see more of disease data than health data, as we call it ourselves. So that, I think with those, I think I managed to cover some of the things in the question. Thank you.
Thank you very much, Dr. Everest, for showing how public health application is vast, but specifically described on the importance of data collection. You shared the challenges that are existing and also how we can suggested ways on how we can improve this. Our next speaker is Dr. Kidekazi Mashoto. And Dr. Mashoto, it is very critical that research should inform policy, but gaps often exist between evidence generated and decision making. So what should be the priority areas in Tanzania's oral health research agenda, and how can research findings be effectively translated into actionable policies and programs? Welcome, Dr. Mashoto.
Good afternoon or good evening.
Good afternoon.
First of all, I would like to thank you for inviting me in this space to contribute to the very important conversation regarding the national oral health agenda, which I believe this kind of conversation should have taken place 20 years ago. We are a little bit late because when I was invited, I tried to search to see that if I can get the national oral health agenda, but I couldn't get one. I managed to get the research agenda for MUHAS, in which oral health issues have been embedded. Embedded in the sense that there are a couple of pages that talk about oral health. But we all know that oral health is broader, so being embedded in the MUHAS research agenda, I mean, it didn't cover much of it. So in short, I would say that we do not have a national oral health research agenda. And the fact that we do not have the national oral health agenda, there's a cost that are associated with the lack of that document. If we do not have that agenda, that means even the prevalence that we are talking about, we are not sure if they are true prevalence. We are not sure of the true impact of the oral disease that we are talking about. And if we are not sure, that means it's become even difficult to prioritize health issues. Why it is difficult? Because we do not have evidence to give policymakers so that they can justify investment in oral health infrastructure.
Partnership and cooperation. I'll urge all parties, and I will welcome all of you. And I think that I have to go and write the invitation letter to all of you to participate in the technical working group. And I'm sure that WHO is here, and the WHO is ready to support these technical working groups, so we can sit together with other people and come up with we come with an agreement, the common agreement, to push forward the oral health agenda in the country. Thank you.
For such encouraging words and sharing with us about the presence of the technical.
Thank you very much. Maybe a compliment a bit for the Zobo questions for the primary care. because there's some mechanism that we can also engage different actors at PHC. So we have the forums, the primary care committees at council and to the level of the wards. But there are some of them at sectoral committee that you can utilize also to get some engagement with different actors. So because technical group is up there, but to PHC, you need those primary care committees. But now coming to the questions of financing. Yeah, financing really is an issue, and reflecting to the primary care, reading the report by the Lancet Global Commissions in 2022, and Tanzania was one for that publications. Investment in PHC, when it talks about finances, in most of the low-income countries is still low. And it's estimated around 16 recurrent expenditures. What we've seen in Tanzania in particular now, there's an increase in investment in finances. It's increasing in the past several years. It's going up. And it's going up, if you reflect even the per capita expenditures going up, but also investment that's going to the primary cares. And, but if you deep dive and look upon the national health account, checking upon the profile of the financing, you realize that what is happening, external finance is dropping, going down. But the domestic finance is going up. But if you check the domestic finance that's going up, mostly it's because of the out-of-pocket expenditures. People are paying from the pocket, and that's the problem now. When people are paying out of pocket, though the domestic financing becomes increases to support health services, including dental services, but that is prone to catastrophic health expenditures. So some people can get more poorer and poorer because of the spendings. Now, today we had here good news from the PS talking about the upcoming UHI. I think that is the way to go, because now we have now to take the potential of out-of-pocket expenditures now to redirect it to the UHI. If you can have that good pool for the resources within the UHI, now we are able now, at least now, to be able to finance the health, including the oral health. That is also part and parcel within the UHI investment. I think that one should go that way. But number two, we need also to think about gaining efficiency when it comes to investment in oral health. Yes, we're talking about a lot of technology here, investment, but in the eye of the health economist, yeah, we need to think about efficiency. And now, the university here to support the government in terms of conducting some of the assessment, health technology assessment, to see whether all the investment that you are bringing on board, are they really efficient, or do we really need to go to a different directions? I think that one is important for now. Sansa.
Thank you very much, Mr. James. Thank you very much for giving us options on how we can be able to finance so that to make oral health accessible and affordable. So before I go to my last round of questions, I'm inviting, if there's anyone in the audience who has a burning question to any of the panelists, please state exactly that my question goes to this panelist and be focused and make the question short. I welcome the audience to ask if there's any question. Okay, thank you. I think I saw her hand first and then you come second. So we can take 3 questions and then we can move forward.
Thank you very much. My name is Dr. Hawa Bawala. I'm a senior lecturer in pediatric dentistry at the School of Dentistry and Madilius. So my question goes to Dr. Nzobo, the Assistant Director for Oral Health in the Ministry of Health. And while he was presenting, he pointed out that there is a set of specialists that are supposed to be allocated in the regional referral hospitals to the lower level as to the district and regional hospital, district hospitals. My question is, the team misses one of the key functional personnel, a public oral health specialist. If we have the surgeon, we have the orthodontist, we have the prosthodontist, so we are addressing the advanced secondary prevention aspect, rehabilitative care, but we are missing out the primary prevention and oral disease promotion. So on those action plan that we are stipulated by the person from WHO, which means the other action is not well addressed because it does not have a coordinator or a personnel that is key in that space. And that is reflected even at MOHAS, that we are missing even candidates to be enrolled in such programs. Either it's not attracted, or now I'm leaving it out, it might be when they graduate, they don't have a space to go upon graduation. That's one. Number two, the same, as I look at the organogram of the Ministry of Health, the assistant director is at the Directorate of Curative Care. The boss is curative care. While dentistry has all the dimensions, from curative, preventive, rehabilitative, lab need, and everything. So minimizing it into just a subsection in the directorate, that is, I'm questioning the governance part. So why is it so? And why shouldn't we furukuta out of that troubles? And then one to my sister Mashoto, it is on the research agenda. We are saying we do not have a nationwide oral health research. Where does it come from? I've seen one of the methodologies that she has applied that we should call a tactical meeting and then come. I think it's coming out of Tanzanian researchers. We are meeting annually in this Tanzanian Dental Association. Maybe it should come out as a resolution on what we want to bring it, and then we take it to Nzobo, and then we get the support on how to operate. So maybe it's not only coming from the top, it should be coming from us as the members who contribute and know what research agendas are driving the changes on the advancement in oral health. Thank you very much.
Thank you, thank you. So I'll invite one more question and then they can be responded.
Thank you very much. My questions was actually started from Dr. Alfonsina, and I think also Dr. Tobo, you can answer it as a part of the Ministry of Health. It's a sort of prevention part. Prevention cannot be done without massive education to the community. Now I want to know what role does the Ministry of Health play in providing education, especially using the digital methods, the social medias, where we know the Gen Z generation is most of people lying there, and how does Ministry of Health employs youth into promotion of health in this current generation, where the youth as a future generation, and we currently not saying youth as a future generation, youth as a present generation. Thank you.
Thank you very much. Before you say it, quickly introduce yourself.
My name is Johanna Makatobe. I'm student, medical student.
Oh, thank you so much. This is really good to see a medical student in this forum. Welcome. So I will just invite the panelists. You can start with them.
Thank you very much. I will start from, if Dr. Howard will not be embarrassed, I will start to answer from Johanna Makatobe. Okay. You have said that prevention without mass education is quite a bit difficult. And why don't you use social media, engaging youth and so forth? At the Ministry of Health, actually, we have social media page of the Ministry of Health. And for those who are familiar with those social media, we have X page, we have Instagram page, we have Facebook page. The oral health education are continuously and consistently being posted to the social media. And I'm sure most of the dentists, they are aware, and they come across with those social media of the Ministry of Health. So we continue posting various oral health education through these social media. About mass education, we have various sections to the radios, to the televisions, and the Ministry of Health, we collaborate with the MUHAS and MNH people. I usually seeking from expertise from MUHAS, from MNH, all those around in Dar es Salaam, where majority of these radio and the televisions are found. We managed to have 1 hour or 2 hour session through the media. So the dentists, they are going there, they are providing various topics on oral health education for the preventive part. But also we use magazines. We use Mwananchi, we use Nipashe, and the Citizens. There are various oral health educations we are publishing to these newspapers. Going back to Dr. Howard, that we don't have public oral health specialists at this level. Yes. Yes, of course. We don't have. In dentistry, we have a lot of specialties. But you know, the resource is scarce. And employing someone who is not in scheme of service, that is very dangerous. You can have a cadre produced in MUHAS going to the market. Once come to the market, that cadre is not in the scheme of service. How are you going to pay the salaries and so forth? So, because our cadre is growing, yes, I know that you really need public oral health specialists at MUHAS. But when I look to my friend Kengia, where he's supposed to implement the oral health issue at Kantalamba. In Kantalamba, we have only dental therapists. In the district, when you count, maybe in the Kantalamba have 40 health centers, but we have only 5 health centers with the dental therapist. The one who is supposed to supervise and doing planning for on oral health at that district level is the district dental officer, a DDS. We don't have a DDS in Kantalamba. We have a dental therapist, a mere diploma in clinical dentistry. So you can imagine, people they say kupanga ni kuchagua. We don't have DDS in Kantalamba. Maybe Kantalamba is the bad example. We don't have a DDS in Namtumbo. I know you are coming from that area. We don't have DDS in Namtumbo. We don't have DDS in Tunduru. We don't have DDS in Inyasa district. We have only dental therapists. So, what are you going to do? Are you going to introduce the public oral health specialist who is not in the scheme of service? Or are you going to increase the number of DDS, encourage them to go for the public health courses at MUHAS? Having an MPH or epidemiology, you will know for some extent how to deal with the public oral health issues, and that disease will help you in the curative part, in the preventive part, and in the other managerial activities. So as the public oral health specialist, I'm not saying that it is not important. No, thank you. It is very important. But we are still growing. As for now, I'm speaking. For the dentist, we are talking about quality oral health service. For the dentist to provide the quality oral health service, he or she has to work with the dental nurse. Do we have dental nurse in the country? even at MNH, they don't have dental nurse. They just use a common nurse being assigned to work at the MNH dental clinic. Okay, this is a full lower molar, and this is a so forth. Okay, this is a GIC mix. This. That is not the quality oral health. The quality oral health service. We don't have a dental nurse for the four-handed dentistry. So, for me, at the sectoral ministry level, because we are growing, I could even advocate on establishing a dental nurse cadre in the country to go and support the dentistry, to emphasize the DDS, to be willing to work at the primary health care level, to the district level. They are going there as the district dental officer, and encourage them to go for the postgraduate study for the public health courses. They will help us a lot. So for now, maybe you can not be happy, but for us at the Ministry of Health, we think we need to wait for some extent for the very good reason. Yeah, thank you.
Yes, thank you very much. Maybe on the organogram?
Oh, sorry. For the organogram, yes, sorry. People now that in the global issue, in the global agenda, we are talking about integration, working together, not working in silos. Yes, there is no health without oral health. Everyone will be happy when they come to the Ministry of Health and they see that this is the Directorate of Oral Health, which is very good. But under the Directorate of the Curative Service, we have 5 sections. We have oral health section, we have the NCD section, we have rehabilitation section, and we have public and the private health service section. Each section has full mandate to decide whatever they see it is applicable in the country. The Director of Curative Service is there to collect what is agreed within the section and pushing forward. And in the Ministry of Health, we have the management meeting. The management meeting is under the chair of the permanent secretary. Members of the management committee meeting is the director of that directorate and all assistant directors. So all decision of the ministry management committee, we are part of it, and we reach the consensus together. So you don't have to worry about the representation of oral health at the Ministry of Health. The representation of oral health is of 100%, and we have all the mandate to decide whatever we agreed with the other oral health personnel that this is really sure it will help us in moving forward in the oral health. So, Dr. Hawa, you don't have to worry. The oral health is in a safe hand. Thank you.
Thank you very much. Maybe we can hear from Dr. Mashoto, research agenda.
Dr. Hawa, please don't be worried regarding who will lead the process of developing the national and also to regulate. But when it comes to a national health research agenda, the ministry, we are doing it on behalf of the Ministry of Health. We are just coordinating the stakeholders from all over the country and prepare the document. But the final say of the person who is going to sign the document is the Ministry of Health. So the School of Dentistry can spearhead the entire process, coordinate the stakeholders, but ensure that it goes to the ministry for it to become national.
Thank you. Thank you, Dr. Mashoto. So I just give 5 minutes. If there's any burning question from the audience. Okay, we have one there. Anyone else? Yes, please introduce yourself.
My name is Arnold Mahega. My question goes directly to Dr. Everest. My question falls under technology, innovation, and data. We all understand Tanzania is still catching toward the pace of innovation when it comes to health. And we know we have the challenge of data. Given the challenge of data transfer, data sharing, while we know we don't have the data, what do you think can be the framework that can be established or support can be given to local developed oral health solutions to create local data that can be used to develop local innovations to support provision of oral health services toward the primary health care?
Yes, thank you so much, Dr. Arnold, for your question. Yes, I pointed out that the major challenge that we have is either data is unavailable or some data are missing or incomplete data. And we know in most of innovations we need information, evidence, to have a decision based on evidence, which is from data, yeah? So unfortunately, I suggested earlier that to solve the issue of database fragmentation and also isolation of available data and missing data, first, we need to establish some controls in the available systems. And by controls, I mean, if you are supposed to fill a diagnosis, that part should not go unfilled, okay? Then we also have to integrate the systems that we use. And by that I mean, you are working with, you are an oral health personnel, but you are not the only person who is seeing patients who may also have oral health issues. So the basic, we should establish basic data that we need to be integrated into other persons dealing with other health issues to feed our oral health data. So we work together, as some of the panelists have said. So by so doing, and I gave an example, say we have community health workers going to the field. They are big potential to have, they are in more chances to have contact with the community. But we have data for the patients. Those are two different data, okay? So for surveillance and for obtaining population data other than patient data, we need people who are dealing with people, health people in the community, yeah? And who are those people? In this example is community health workers going for other things, maybe not oral health issues, but we have developed a special package for them related to oral health, so we can harness their potential from the field. And so through that, I believe over the years, we will have data for innovations and for planning and decision making related to oral health, even though not emanating from oral health practice in the community or oral health programs in the community. Yeah.
Thank you very much. Dr. Everest. Maybe you should just hold on to that. So I will just give my final round of questions. And this goes to all the panelists. We have been talking about how important it is to have actionable commitments. So the global strategies emphasize turning commitments into measurable local actions. Given the discussions that we had today from the special guest as well, what are the top 3 immediate actions each panelist believes should be prioritized in Tanzania in order to advance oral health within the universal health coverage over the next 1 to 3 years, and how can progress be monitored? So maybe let's start first.
Okay, thank you, Madam Chair. So maybe I should again go back to my issues. First, we need to review the systems that are in place, and then see their content and standardize based on what we want, the data we want to harness from those available systems, but also to make the most, to have more sources of data that we need for decision making. We need to integrate our systems into other providers, but also to extend more than the clinics. We need to involve, we need to develop packages of information that we need from the community and utilize people who are daily into the community to bring us data for our consumption. Apart from that, I think it's high time that, I know we are talking about more of data in management, but we also have data for service provision or service delivery. I haven't talked much about it. Now we know that if we have interconnected systems, the transitions of patients from one point to another is made easy and more efficient without cost. Nowadays, because of these systems are not integrated, the patient will take X-ray from one point and will be required to take the same X-ray when he comes to another point of care. And that adds cost to the patient, to the facility, and probably to the government. That's why we need to integrate so that communication and smooth patient care is covered. But again, I know here Dr. Nzobo has done a commendable job when it comes to curative services, empowering facilities and individuals. But we know there are some devices that cannot be supplied to all facilities. The former dean has said at MUHAS we have a 3D, we have CAD/CAM systems where we can offer services chairside, shorter period, which are more expensive. We cannot supply to probably all the facilities, but there is a potential for, satellite labs. Satellite lab in a way that you can supply scanners to a few facilities, maybe every zone, and they can scan their patients and send it to a satellite lab. So here can be MUHAS as a satellite lab where they can design and do the milling or printing and bring back the product. That becomes cost effective. Patients receive service, quality service that they need, but also at a cheaper price. You're using one lab, you just supply scanners instead of supplying scanners, milling machine and printers to every facility. So that was a by the way in the digital tech. Thank you.
Thank you.
Thank you very much. I think 3 important things. One is access through investment at PHC, over area that we have discussed here from the health promotion to rehabilitative services. And I agree with the colleague here with regards to even embed the telemedicine, teledentistry. And at this point in time, for PHC, all the facilities, we have installed the GoToMist, Government of Tanzania Health Management Information System, that also had a module for the telemedicine. So we can also see how we can invest on that one. The second thing is, of course, tapping the potential of the upcoming implementation of HI. I think that is key. The third one is the MERIL, monitoring, evaluation, research and learning, to becomes part of our agenda. Thank you.
Thank you, James.
Yeah, thank you. One thing is that the preventive part of the oral health, I wanted to, my mentor, my teacher, Dr. Masal, we have just finalizing the standard treatment guideline and the national essential medicine list, whereby the fluoridated toothpaste is under dental caries prevention strategy within this STG. Also, the silver diamond fluoride is within the standard treatment guideline under dental caries preventive part. Also, we have the fluoride gel, also there together in the STD. So after the endorsement by the Permanent Secretary and the Minister of Health, these fluoride components will be part of the National Essential Medicine List, and we are going to move them from TBS to the TMDA to be regulated. So when it be regulated with the TMDA, those issues, the bioactive ingredients will be monitored by the TMDA laboratory. So I want to make it clear, you don't have to worry, all things have been taken care. We are waiting for the endorsement. But second is the environmentally friendly dentistry as one of the WHO Global Oral Health Strategy. As Tanzania, we have fully achieved phasing out of the dental amalgam, and we have replaced it with the Centurion N. But we know we have other materials, non-amalgam materials, the glass ionomer, the zinc, the composite, and so forth. So I urge the MUHAS and the other dental training institution to continue capacitate their students on the use of this non-amalgam dental material, but I'm sure that Centurion is not already taught in MUHAS, so you have to think to include it during dental material training program, because we cannot go back again. So you don't have to think that at the certain time we are going to go back to the amalgam. The amalgam will be in the archive that for the quite number of years we used the amalgam, now we are using Centurion. And I want to tell you that Tanzania is among of the very few countries who use Centurion. We calculate the costs of buying the material. We calculate the number of cavities can be filled with 15 gram of Centurion and 30 gram of Centurion. The all health facility who use Centurion, they attain maximum profit. So there is no loss to the government, there is no loss to our health facility. So I urge you, even the private dental clinics, please go and use Centurion. If you don't want to quarrel with your patient, you know the private, they are making business. Use Centurion and all conflict of your patient will be solved out. Thank you.
Age ni kitu kizuri. Now here I'm supposed to propose immediate actions that can can be done during the next year. It means the action must be in the budget. Hii budget ambayo imeshapita sasa hivi ya nzuri. Ndio maana yake. In that regard, I'm glad my desire is to have this affordable fluoridated toothpaste. That one does not require budget, and I'm glad the director here is reporting that things are in the right direction. Probably from next year, toothpaste and toothbrushes will be therapeutic products and not cosmetic products. So that one, I had prepared it to make it as a request to the Jamhuri, and I'm glad it has been taken care of. Taxation, to revoke taxation on toothpaste and toothbrushes. Probably it is part of putting it under medicines, but just to make sure that no taxation, so that many Tanzanians can have access to fluoridated toothpaste. The third one would be to prepare an intervention model that can be tested. That is the next budget year, not this one, because this one is already gone. But if there is money, I would be happy to see that Tanzania develops an intervention package which is tested and it can be rolled over to be used throughout the country. That would be very good. But just to remind the director that our previous national survey was done in 2020, although it was published in 2022 or 2021, probably we can think of putting ourselves on a gear of conducting a next one. If not this year, then next year. Because we are required to do it after every 5 years. Thank you, Madam Chair.
Asante, if we really want to effectively translate research findings into actionable policies and programs, first of all, we need to ask ourselves, what kind of evidence do we really generate? If we keep doing the CAP type kind of research, no policymaker will use that evidence. I'm not saying that CAPs are not useful, but we all know if you put them in the hierarchy of strength of the evidence, they score low. So nobody would want to make a policy or change practice based on the CAP evidence. So we really need to change. We should now focus into rigorous research in terms of clinical trials, cluster randomized trial, field trials. Those have heavy evidence that can be used by the policymakers. But once we have the results in our hands, how do we communicate such findings to the extent that policymakers decide to use them? So we really need to assess ourselves. Are we really capable to package our results in such a way policymakers will use them, the public will use them to change their behavior, and programs will use them for programming. So I think we need to improve how we do our research, but also how we communicate our findings. but we also need to have knowledge translation platforms. Before even we start doing our research, we convene with our policymakers, managers, program managers, even the public, so that we know what they need. That way to become easy for them to uptake our findings, rather than us sitting in our own office and trying to come up with our own problems. At the end of the day, we go and present to them, they won't take it. So we need a platform like this where we have all the stakeholders. We need to map who are our stakeholders.
Thank you. Thank you very much, panelists. I think we have captured all the actionable items, and they are featuring very well, and some of them are similar, mostly geared towards prevention of oral health or oral disease through utilization of different methods. But we also, how important it is to have quality data so that we can have be able to convince policy. We also need to have correct types of studies. This is a challenge to possibly most of us here. What type of evidence do we need to, so that we can be able to convince policy? So we need to have more field trials, clinical trials and the like, so that we can be able to create evidence-based information and how we communicate it, and in order to get the from policymakers. So, ladies and gentlemen, and dear panelists, I would like to thank you very much for your time, and we really apologize for being late a little bit, but we really appreciate your patience. And this marks the end of this session, and now I would like to call upon the MC so that we can go and finalize the next sessions. Thank you.
I think we can do much better for the panelists. They have done, and the chairperson as well. They have done a great work. We can do much better. We can even stand so that as they get a standing ovation for that. They give justice to us. Thank you very much, and I really would like to thank you so much for being very patient. We have gone above our time, but I think it was very important that we finish everything. I think you agree with me, it was important, was it? Yes. Now I'd like to welcome the Director of Research, Publication and Innovation, Dr. Naya Masood, and she's going to give us our closing remark. Karibu sana.
Sorry for keeping you in this room. I think it was a very important matter to be discussed together as a platform to move and progress ourselves to the next milestone. Without taking more time, I think it was a beautiful afternoon, and I would like to provide special thanks from the management of Mopas to our guest of honor, the Permanent Secretary, Dr. Sef Shekelagi, who was here with us this afternoon, as well as our keynote speakers. I think we enjoyed the talking, the take home and the milestone, specifically for the Center of Excellence for Dental and Oral Health, which is more exciting for the future of Tanzania. And special thanks to our Assistant Director, Oral Health, Minister of Health, the Coordinator Research and Publication, Pure Raj, from the primary healthcare level, but also Dr. Everest Wilson, our own, who has a lecturer, essential technologies in oral health, which is very critical. Dr. Joyce Masalu, our teacher, thank you so much. We always learn a lot from you. Dr. Getas Mashoto, my colleague also from Commercialization, Innovation, and Technology Transfer, NIMRI, and all the participants, the coordinators of this 15th MUHA Symposium, and also without forgetting our own funder and sponsor for many years, the CEDA, the Embassy of Sweden by the Swedish International Development Cooperation Agency, CEDA, who has always been along with us to support this dissemination platform. So without saying thank you and goodbye to all of you, I read something in the background of the situation analysis on the dental and oral health. And what has been exciting here, I have been learning that over 90% of caries experience is within the age group of 5 years, 12 years, in 15 years. So the children and adolescents, which I think for me this is a forgotten group, and we can easily integrate the care into the existing platform through the RSH follow-up and have the indicators within that to track our oral and dental health to our young ones. So I just noted a few points when the panelists were summarizing, and I think these are very critical issues. The first one was review the system, standardize, integrate, and extend the information package to the community. So I really love this because if you look at our DHIS2, the GoToHomes and the Afya Care system, what we're missing is the linkage to the community, but also integration throughout the patient journey, which actually was echoed as the second point, that transition of patient. So for me, this is a patient journey. Where you start and where you end for care needs to talk to each other throughout the continuum of care, especially now that we are moving to the universal health coverage, and now specifically for dental health. So while these data are integrated and the data are talking to each other from one level to another, I think this will make our life easier, but also support the third point, which is actually was satellite hubs or labs. And now we are talking about digital hospitals. So for the hubs, the satellite hubs like MUHAs, for example, you can imagine you have a center of excellence for oral and dental health. Then that could be a digital hospital supporting other feeders as spokes to provide technical know-hows, but also receiving some technical challenges to be supported timely with the professionals who are sitting in this digital hospital, analyzing whatever is coming in and giving timely feedback to the patient, but also professions who are sitting at the lower level who requires that level of care, high level of care or consultations, which can support quality care to be delivered timely to our community. And the other part which I loved is the essential dental medicine list, which is really supporting the hallmark of the health system, building blocks towards good quality dental and healthcare services. High quality research and knowledge translation platforms, and utilize data uptake for national targets for the benefits of Tanzania. I think this is also critical, and part of it is what we are doing now that requires more strengthening. So to all of us, I think we still have a lot to do in terms of progressing ourselves to the universal health coverage, but also quality care in terms of dental and oral health. And I thank you again for your hours in this afternoon to complete our 15th MUHA Symposium on oral and dental health. Asanteni sana. So do I have to declare that the 15th MUHA Symposium is officially closed? Thank you.
Sasa wewe una iPhone bana? Njoo nipigie basi na simu yangu.